Good morning. Good morning. Good morning. It's 10 o'clock on Monday, the 3rd of October. It's the first time we've met in nearly 2 months, and we've certainly got a packed agenda as a result. So I'm going to restrict my comments so that we have as much time as possible this morning to scrutinise the papers and presentations in front of us. As a result, I would ask members to be brief in their questioning, in asking questions, and not too long, rambly questions, and to focus on county-wide issues and not to try and slip into questions that relate to very local or personal matters, and not to ask questions that have already been asked and answered in the chamber this morning. That said, if you don't ask a question on an issue of note or of concern that you do have, then silence will be taken by all in the system to be a position of acquiescence. So please do positively challenge our guests this morning, but do it in a productive and positive way, please. So on that note, welcome to our guests, both virtual and in person. And welcome to Staffordshire's Health and Care Overview and Scrutiny Committee. I am your Chair, County Councillor Jeremy Pert. May I remind committee that today's meeting is being recorded, and for those who want to watch today's session back, the recording can be found on the County Council's website. The meeting is also being beamed live for people to be involved and will cut off 20 seconds after the equipment has stopped. All voting committee members are in person, and there is a variety of people in virtual attendance as our guests. Could I ask our guests to accept that members have read and digested the papers provided, and as a result restrict comments, opening comments, to 5 or 10 minutes depending on the item. We have a really packed agenda, so I would ask that our presenters took that on board. And secondly, that we focus on tangible outcomes for the residents of Staffordshire. Let's use the data and our experiences to sharpen the quality of debate to ensure that we are going in the right direction for our residents. Okay, so that takes us on to the agenda. I should just say also that I do plan a hard and fast stop at 1 o'clock, just so that people can be aware of that. So first of all, apologies. I have apologies from quite a few. Do you want to do those?
Yes, thank you, Chair. Apologies from councillors Jack Abrahams, Richard Cox, Lynn Hingley, Phil Hewitt, Ian Wilkes and Cabinet Member Julia Jessel. Councillor Phil Atkins will be arriving late, Chair.
Thank you, and I'm sure every member would want to pass on our best wishes and thoughts to Councillor Richard Cox. So, declarations of interest. Do we have any declarations of interest in this morning's agenda? Councillor Anne Edgeler.
How much should I be this one? This one, okay. Sorry. Good morning, everyone. Yes, I'm Partner Governor for the County Council on the Midland Partnership Foundation Trust.
Thank you. Noted, Bernard.
I am the Staffordshire Local Authority appointed Governor at UHDB.
Thank you very much. And just for the minutes, can I just confirm we're quorate?
We are quorate, Chair.
Thank you. So that moves us on to item number 3, which is to approve the minutes of the 11th of July and the 1st of August. So first of all, let's approve the minutes of the 11th of July. Can I ask if the minutes are a true record of our last meeting? For those of...
Good morning, Chairman. Just one alteration, please. The substitute, Councillor Steve Norman, represents Lichfield, not Tamworth. Thank you.
Noted, and we'll make that amend. Any further changes? Okay, let's... are we happy to proceed that there are... Thank you. Everyone else in agreement? Okay, brilliant. Thank you. I'm reliably informed that all actions have been followed up and all information has been circulated to members. So let's move on to the 1st of August. Can I take the minutes as a true record of our meeting from the 1st of August? Few nods. Are we in agreement? Yep. Okay. Any dissenters? I'll approve those on. Okay, that takes us on very briefly onto the integrated, no, sorry, there you go, nearly had a few people worried there. That takes us on to item number 4, system pressures. Phil, I believe you are leading out on this. Do you want to introduce, good morning, and do you want to introduce your colleagues who are with you? Actually, it doesn't, it's Peter who looks like he's leading.
It is, Chair, yes, thank you. So hopefully people can see me. I'll just briefly introduce this item and then I'll hand over to Phil. We've got a few slides to share, and hopefully Ruth, who's on the call with us, will be able to do that in a moment. But if I just do introduce who's with us, and then we can, well, you'll be able to know who to hand questions over to, etc. in a moment. So on the call today, we've got Jenny Collier from MPFT, Mark Doherty from WMAS, West Midlands Ambulance Service, Paul, by the way, from UHNM, as mentioned a moment ago, Phil Smith from the ICB. We've also got observing Steve Fawcett, who's our clinical lead for UEC. So if I could just very briefly introduce the item, then as I say, I'll hand over to Phil to go through the detail. What I want to do is really just provide a little bit of context in terms of the position nationally. So as Phil will describe in a moment, the system within Staffordshire is very pressurised, but that is the case broadly across the nation. I think COVID has caused a level, generally, prevalence of ill health, poor health that we've never seen before. And as a result, that's impacted on all UEC urgent and emergency care systems across the country, unfortunately. And a number of systems across the country have heightened level of demand, heightened levels of pressure within the ambulance service, and significant pressure within local authority services, particularly that discharge piece through domiciliary care. So I just thought it would be useful as we go into the conversation about Staffordshire to give that broader context, that is, this is a national problem as much as it is a Staffordshire problem, and significant conversations are happening at the centre. Funds are hopefully going to flow to support winter, which in itself is very helpful. I think you'll perhaps be all aware of the £500 million announcement recently in terms of social care support. That's great. The challenge for us, I think, locally and nationally, again, is the ability to staff that, to spend the money on staffing, given the level of pressure we have on our existing workforce, let alone that opportunity to be able to appoint to additional staff. So as we go into winter, we do have significant pressures, as I say, not an outlier compared to colleagues nationally, but all the same, quite a significant worry. Okay, I thought it'd be useful just to provide that national context, as it were, and then I'll hand over now to Phil Smith, if that's okay, to take you through some of the detail more locally. Phil?
Okay, good morning, everybody. Thanks, Peter. I'll talk you through some of the slides, and obviously you've seen the report to support this. So as an NHS, we formally moved from level 4 incident nationally to level 3 in May this year. However, clearly we've continued to experience significant local pressures in terms of urgent and emergency care strain across all elements of the pathway. So at the start of the financial year, we saw a COVID spike, which once again, as with previous waves, impacted on staffing capacity and flow. Pressures have continued throughout the summer, even when COVID has dropped off somewhat. And as we talk to you again, we are in, once again, a very difficult operational environment, and we are indeed seeing rising COVID levels once again within care settings. So, as Peter said, we're certainly not alone in terms of the level of sustained pressure we are experiencing, and workforce and capacity constraints and a notable increase in the acuity of patients compared to pre-COVID considered to be the key drivers here. And although the current challenges we see often played out in the media are framed in terms of the unacceptable level of ambulance handover delays we're seeing at acute trusts, we're clear that addressing the challenges of ambulance handover delays relies on us all working together as a health and care system to address all parts of the UEC pathway. So all partners have a role to play in this, and it's really great that Mark Doherty from the Ambulance Services has joined us today as well, and I'm sure we'll add some thoughts as we go through this. So we should note that the Royal Stoke site is one of 12 in the country currently receiving national oversight and support in relation to handover delays. This has meant some funding. It's also meant sharing of best practice and links with national experts on the topic. So the paper, as set out, provides detail on the interventions we're taking at each part of the pathway to improve the current position. I'll draw out a couple of specific examples of actions being taken, drawing on the learning this year, but then also crucially just talk about how we're planning for the remainder of the year, which we're expecting will be difficult. So I should also just note before I go on that the paper focuses around the operational actions and interventions to respond to the current pressures and plans for the rest of the year. It does not detail all of the work that's going on in the prevention agenda, which, as we all know, is at the very heart of making sure we've got a sustainable long-term solution for our urgent emergency care system. If we can just move on to slide 6, please, if that's okay. So we group our interventions in a set of areas. So this one sets out pre-hospital. So there's a range of initiatives here which seek basically to ensure that only the patients who clinically need to are conveyed to hospital. We know there's already been significant progress in this area and that WMAS see and treat levels perform well against other areas, but we also know there's a lot more we can do. So, for example, over this summer, we've been working on a test of change involving our Community Rapid Intervention Service, working closely with WMAS colleagues to support paramedics to navigate patients to alternative community services prior to them needing conveyance or presentation at the emergency department. We've seen success with this and are continuing to build on it. And indeed, from today, we've now got a member of that community team based within the local ambulance control centre to help target patients before an ambulance is dispatched. So the CRIS was initially working, the Community Rapid Intervention Service was initially working on the UHNM footprint, but is now expanding to serve the whole population of Staffordshire and Stoke-on-Trent. So the data shows that although we're experiencing challenges at all acute sites in terms of ambulance handover delays, the most significant proportion of delays, as we've already said, are at the Royal Stoke site. So the key specific initiatives underway here are increasing the cohorting capacity at UHNM to enable ambulance crews to be released. We've launched a pilot within space alongside the ED department for a frailty decision unit, which brings together acute, community and social care colleagues to treat those presenting with frailty issues at the front door, avoid admission and hopefully bring them back out into their usual place of residence. And there's also national investment been made in expanding the footprint within the emergency department at Royal Stoke to increase capacity. If we can just jump on to slide 8, please. Thank you very much. Thanks. Looking at in the hospital, so all of the hospitals serving our residents are looking at balancing the risk across their sites. This means looking at the level of risk on the driveway, if you like, in terms of ambulances queuing versus that in the emergency department versus that in the hospital wards. And we're looking across all sites to implement schemes to balance that risk, essentially, decongest the ED, decongest the ambulance waits, but we're clear this must be done in a safe and risk-assessed manner. And moving forwards, our clinical and professional leads are looking at how this risk can be managed more evenly across the whole health and care system. So this isn't just about spreading the risk within the acute footprint, but looking at what all partners can do in this space. And similarly, in terms of the acute hospital space, the winter capacity plan we're developing at the moment will see investment in additional acute escalation wards as we move through winter. We can jump on to slide 10, please. That's okay. Thank you. So we know that hospital occupancy continues to be high and much higher than we would want it to be. So we've got to maintain our focus on discharging patients in a safe and timely fashion. We've certainly seen a shift in the proportion of patients requiring ongoing care through what we call a complex pathway versus a simple discharge, those needing no onward care, since pre-pandemic. And this has driven up the demand for community and bed-based and then ultimately social care provided services, which is presenting further strain on domiciliary care and care home provision. We've got a discharge review which is just about to commence, which is led by local health and care clinical and professional colleagues, which seeks to understand the operational processes, the decision making and the risk management in terms of discharge. And then we've also got investment in additional discharge to assess rehabilitation beds and community capacity heading into winter. We have seen large numbers of patients stuck, for want of a better word, at the back end of these reablement services, with particularly high numbers in what we term as provider of last resort, where patients are waiting to transition onto an ongoing domiciliary care package. These are largely now centering around the state footprint rather than Staffordshire. We've seen significant improvement in Staffordshire linked to the investment made in building an in-house provision and incentives to the market, but it's clear that both the domiciliary care and care home markets are increasingly fragile across our whole geography. So this is a really fundamental issue that we need to work together to address. We can move on to slide 11, please. So we've got a cycle of rapid improvement weeks in the system which involve all partners, and learning from these, along with bank holiday periods and other periods of pressure, are built into our forward plans. As a group of system operational leads, colleagues from health and care meet on a daily basis, 11:30 every morning, to discuss escalations and agree the tactical actions that we are taking. If we just move on to slide 12, please. Thank you. So winter, as I've said, we know will be extremely challenging. We are assuming that we will have an increase in non-elective demand, which is what you would traditionally see during winter. And then we're also factoring in flu, which we know has been really high in the Southern Hemisphere, which tends to be a lead-in for what we will see. And then also a further wave of COVID. So we have to build capacity plans that take account of these, but also critically, as we'll come on to later in the performance update, allow us to maintain our elective and cancer services so that other services are not impacted by the management of urgent care. We've received national monies along with those allocated locally by individual organisations to provide additional capacity. However, we know that workforce availability will be the key issue. We've got a range of initiatives underway to attract new staff, encourage existing staff to carry out additional or different duties, but we know that will be our fundamental challenge, if you like, as we move into winter. I'm just going to pause there and basically just emphasise that health and care partners are working together to manage the pressures, drive improvement and plan for the months ahead, but we know that these workforce and acuity challenges are going to be with us and are going to be ever present in the next 6 months. So I'll pause there. I know we've got colleagues from UHM, MPFT and the ambulance service on who may want to add comment to what I've just said.
Phil, I'm just waiting for any of your colleagues to indicate whether they want to add. Now, on that basis, let's move into... Phil, thank you for the presentation. Peter, thank you also for the overview as well. Let's move into questioning. Before we take a question from committee, I just wanted to pick up two issues. You mentioned flu and the higher prevalence in the Southern Hemisphere this year. Presumably, you would be trying to encourage everyone to take their flu jab and a COVID booster when they become available, and to act as advocates for others to do so. That's my first question. And second of all, you mentioned health and care, and you have a few paragraphs in the pack on health and care. But given the criticality of health and care to patient flow, as you describe it, do I read anything into the fact that this is a health rather than a health and care presentation, or have I missed something in the narrative? Thank you.
Shall I begin? So, in terms of the vaccination program, historically we've got, we've achieved excellent performance over the life of COVID in terms of the COVID jabs. The flu jab obviously now is needed to be rolled out in parallel with the latest COVID boosters. And by all accounts, we're doing an excellent job, whether it be relatively compared to other systems or absolutely in terms of the numbers that so far we've achieved in terms of vaccinations. We've got both fixed locations and roaming locations, so vaccinations on wheels, facilities on wheels. So we're hopefully covering all bases when it comes to vaccination this autumn. And I would absolutely advocate and support the point, Chair, that you've made in terms of the importance of individuals, particularly those with complex needs and conditions, in receiving both of their vaccinations. Colleagues may wish to come in and add comments to that. So just pause for a second. If not, just on the second point, we've got really good relationships with both local authorities, both the city and the county. And as Phil mentioned, those 11:30 calls and occasionally 4 o'clock calls that both happen in the week and the weekends. And I was on all 4 of those calls at the weekend. Local authority colleagues from both the city and the county are represented invariably on all of those calls, and I'm quite sure are doing all that they can in the moment to address the issues and the challenges that we've got. What I would say is, personally, I think there's an opportunity to take a step back and understand how we can perhaps tweak, adjust our arrangements across that health and social care interface and social care provision. And we're going to do some of that as part of the discharge review exercise that Phil mentioned a moment ago. What we can't do is within that is, of course, risk destabilising winter. So any findings that we have that we could quickly implement and put in place pre-winter, we will do that. But any bigger picture items that logically you wouldn't want to implement for risk of destabilising winter, we will make sure that we do at the earliest possible opportunity. And all parties are signed up to that discharge review exercise, both health and local authority colleagues. So what I would say is, let's see what comes out of that discharge exercise that's going to be clinically and professionally led, I would add as well, as opposed to managerially led. So getting into the heart of fundamentally what we're doing well, but also what perhaps we could improve when it comes to that that discharge element of flow.
Peter, thank you for that. That's very helpful. Charlotte Atkins.
Yes, before I get into my question, I can't allow you to get away with saying that the vaccine programme is going well. On Friday, people were queuing for 2.5 hours in the pouring rain outside the Leek fire station to get their COVID jabs. One 86-year-old gentleman asked if he could possibly sit down. No, you can't sit down. It is full. He was left in the pouring rain. What is the point of people getting COVID jabs if they get pneumonia in the first place? It's absolutely outrageous. I was told in this committee on July the 11th that there would be a walk-in vaccination centre at Leek Hospital. So what do? You put it at the fire station. You know, at the end of September, in Leek, I'm sorry to tell you this, but the weather is not glorious. It rains, it is windy, and we are talking about an elderly population here, and you're expecting them to stand for 2.5 hours. Take that back and sort it out. Now to get on to my questions. At 1.7 on the document, you talk about workforce numbers have not achieved planned growth, and you talk about the significant number of people leaving the public sector. What initiatives are you developing to deal with that? Because it seems to me that the pressures within the health service are basically down to workforce. Unless we can get that resolved, then we're not going to get we're not going to get the capacity issues resolved. And the second question I want to ask relates to you've received 10.4. You've received 5.7 million for capacity schemes. Is that funding sufficient, or is there a gap in funding? Thank you.
Who's picking that up, please?
Okay, so we've got Mish on the line in terms of the workforce piece, so we can just provide a couple of comments in terms of the key initiatives that were put in place there. Just on the money, I don't think the money is the issue. I think the workforce, so it's intrinsically linked to the first point, I suppose, is what I'm saying. I think the workforce challenge is the issue, assuming that we can utilise existing fatigued, hard-working staff to manage the broader capacity agenda that we've got through winter is naive. So there is an expectation that we will have to obtain additional staff in some way, shape or form, and that's an extremely challenging ask, and that's a national piece, it's not just a local piece. So for me, all of these conversations are orientated around what I would see as our biggest risk, which is workforce, not the money. So Mish and Phil, you may want to come in afterwards, and other colleagues, of course.
Thank you, Peter. And, absolutely agree that workforce is our biggest challenge. We have been working as a system for, 4 years now, incrementally growing our willingness and trust to work together to develop workforce solutions. I think we're all cognizant of the challenges and the reasons for them. So burnout due to COVID, and we do have an ageing workforce as well as an ageing population. So we have seen an increase in turnover both in the NHS and in social care. There are various schemes that we've put in place to try and address this, knowing that some of them will be short term and some of them are going to be medium to long term in terms of their effectiveness. The first one I want to talk about are the different types of roles that we put in place. So we do have the reserve model now, and I'm sure that colleagues are cognizant of that, and we've talked about it before. We've got several different types of reserves. So within Staffordshire, we have corporate reserves that work within the public sector that actually step up and support us when we have escalation. So we've trained people from scratch. We also have the new to care reserve. So we are training people, so without destabilising the market, so we're not recruiting from social care that are already in existence, we're training new to care people so that we can create a new workforce. And again, they will be supported into permanent roles or work flexibly. Work-life balance is a massive issue for people. They want to work as and when they can and where they can. And for us to do that, we've employed retention coordinators across the 3 trusts and also across social care. So trying to really understand the problems, and for example, one of them will be supporting in rota coordination to try and get some good practice so that we can change the hearts and minds of managers who are stretched, they're tired, and they can't, see the wood for the trees in terms of how they can offer more flexible and innovative rotas to people. But absolutely accept the challenge. This is something that we are going to be working on for, I don't know when it will stop, will it ever stop, but workforce is our biggest challenge. So yes, we've got vacancies. Yes, we're going out for innovative recruitment. Yes, we're doing international recruitment. But for me, retention is the biggest challenge. We need to keep people wanting to work for us, offering them different solutions and listening to them when they're raising concerns. Peter, I don't know if you want me to go into any other detail. I'm really happy to, or to take any other questions.
No, I
just
don't
wondered
think
what
so.
Sorry, can I just interject? If you don't mind. We're obviously got a workforce planning session on the 17th of October. So I would just encourage, I think it's a really important point, but I guess we'll have both Mish and Peter back in the space of a couple of weeks, if that's okay. There were 2 other questions, I think one related to, sorry, Phil, did you want to come in on this specific, or are you picking up the other 2 points that Charlotte made?
Thank you, Chair. I was just coming in terms of the financial investment point, just building on what Peter has said before. So the money allocated nationally has been allocated to each system up and down the country, if you like. But in addition to that, there is investment by each constituent organisation within the patch in terms of winter capacity as well. And then we've also received other funding for initiatives such as virtual wards, which is very much at the centre of the national agenda as we move forwards as an NHS. So we're not limited to the 5.7 million, if you like, that there's significantly more money that is being invested both directly in winter and in other transformative schemes. Thank you.
Thanks, that's helpful. And presumably somebody is going to take away the point in terms of the leak fire station and come back to Deb's so that we can go back to Charlotte. Is that the case?
Yeah, let me take that away. Clearly, that's inappropriate as an arrangement in a situation. So apologies to that resident. And yes, I'll take that away and we'll act.
Thank you, Peter. Charlotte, is there anything else? And Angela.
Thank you very much, and thank you for your report. And one item that you mentioned into is about the Midland Partnership Foundation Trust doing a review on discharge. When will that be completed? Have you any idea? And when will we see an improvement, please?
Yeah, so it's, sorry, could I come in there, Chair? So it's a system-wide review. So we'll be overseeing it as an ICB, given the fact that it's one of those things that it's relevant to all partners. So it would be unfair to ask any one of the provider organisations to take it on. So the ICB is embarking on that now. Steve Fawcett, who was also on the call, actually is both a GP within the patch, but also is clinical and professional lead, recently appointed to the UEC portfolio. And Steve will oversee that work with colleagues, with system colleagues, and will be supported, overseen it by him, will be Paul Edmondson-Jones, who's the relatively new now, I suppose, Chief Medical Officer for the ICB. So as I say, a clinically led piece, but done through the ICB. In terms of timing, Steve, could I just ask you, what sort of timescales are we talking about?
So we're looking to do a review of because we've had all the partner feedback now. We're looking to do a review of those feedback over the course of this week with a draft plan to be developed for next Monday. I just need to be clear with colleagues, this is a very wide-ranging review. We're looking at a whole series of different elements within the discharge journey of the patient. So we'll be doing the working stages and reporting in stages. There won't be discrete pieces of work, but we will be doing elements in a sequence because it makes more sense to do it that way. It's going to take quite a lot of workforce to do the review, so we want to make sure we get it right.
Just in terms of those timelines, thanks, Steve. Useful. Are you suggesting that you would bring that back to committee in November, for example, given that it sounds like it's something which is on your fast track?
So we can look to bring an update, Steve, presumably, can't we, to November? Yeah.
Just to add in, Chair, that we may not have the complete study by then, but we would hope to have a large element of it's completed by the time that OSCE meets again in November.
Would that be beneficial to committee? Yep. Okay, we'll liaise with you on that. Obviously, timelines sometimes move around, so we'll make sure we get it to the right appropriate meeting, and then let's take it from there. Anything else, Anne? Jill Hood, please.
Thank you, Chairman. It was said that the work-life balance of people wanting to work if and when they can. I would think if we can find the answer to this, then we would be benefiting every employer in the country, because I think we're at crisis level with people after the pandemic wanting to work from home, not going out to work, which of course we can't do. Recruitment, yes, hugely important, essential, but I think we need to find a solution somehow to this work-life balance. Thank you, Chairman.
Is that one for Mish, Peter, or is that...
I suppose all I would say, absolutely. It's a really tricky one, of course, because you can't, and we would never expect to make people work. So additional hours over and above contract would only be at individuals' discretion. We also need to be really mindful of burnout, of course. The last thing that we would want to do is to ask a substantive member of staff to go over and above, and then effectively they're not available for weeks or months after that, because that'd be fundamentally counterproductive. So it's a really tricky balance to ensure that the workforce, the existing workforce, we maximise productivity, whilst at the same time finding wherever we can suitable additional staffing from the wider population. So we have to do both recruitment and retention, but it's there's no golden bullet to this. There's no golden bullet. It's just continual activity in terms of recruitment and, you know, really strong, thorough vigilance in terms of oversight of the existing workforce's health and well-being. Really tough. And I think all industries, to a greater or lesser extent, are dealing with the same challenge, aren't they?
Thanks, Jill. Just on that piece, Peter. Obviously, there's a link back to the next item agenda, which is catching up some of the backlog and system performance. It does strike me: have we got the right level of flexibility to be able to match, you know, when there are urgent priorities and a greater backlog in certain areas, to be able to move people dynamically through the system? Because you know, one day we might need to be doing one job, but next day actually the system might need a different job. Have you got that flexibility?
Yeah, so I've been really impressed with UHNM, and of course we have other system partners that do support the elective backlog challenge that are outside of the geographical boundaries of Staffordshire, but predominantly UHNM are our main provider in terms of that backlog management, and I've been really impressed with their ability to deal with that backlog. We're ahead of the curve when it comes to 78-week delays, and we are managing in line with the national expectation around 104-week delays. So really well done. But you're right, Chair, the challenge is to ring fence that capacity, ensure that it continues, is available, whilst acknowledging and managing the level of pressure through the UEC pathway. And that will become harder and harder as late autumn and the winter bites, and everything that we've just talked about in terms of mitigation through workforce, through additional capacity, and what we also call non-capacity, which is effectively management of pressures using other operational mechanisms and balancing risk across the system, which is a really tricky thing to do and manage, and all systems nationally are wrestling with that challenge. But doing all of those things to the best of our ability is the best way, really, to ensure that we get the balance right between elective and UEC pressures, Chair.
Thank you. Bernard Peters.
Thank you, Chair. Listening very carefully to what's being said today, I'm just getting a bit of a gap in my mind around an adequate communication strategy. The public understand, perhaps, that there's going to be a 10-hour wait in A&E. They understand, perhaps, that it's going to be 6, 10, 8 weeks to get the results of an MRI scan. And they understand, perhaps, that there is a backlog, but they can get no appreciation or understanding of when their turn in the queue will occur. Now, what is creating that communication problem? Why is there any opportunity for you to relook at communicating with the public on these significant issues, which are considerably aggravated by this recruitment and retention policy? Thank you.
Who's picking that up? We might be between virtual and in person there, are we?
Yeah, Tracy might want to comment on comms more generally. And we've got provider partners, if it's specifically in relation to individuals on a pathway, individuals awaiting treatment or diagnostic results, for example, then system partners, whether it be Jenny or Paul, might want to chip in. But is there anything generic, Tracy, that you want to comment on in terms of communication to the population?
Thank you. Yes, and we continue to have a dialogue with our population about healthcare. If it's individual places in a queue, I think that's more, like I say, for the providers to answer, and it's around where they are and based on need as well. But I'm sure that the providers can answer that. We are looking towards winter, certainly with our communication to the public, what they can do to help themselves as well, to keep well over winter. There's self-care, the vaccinations, everything else like that. But also where you can go to get your support, because I understand and appreciate sometimes it can be quite difficult how to navigate the NHS. So that's something we'll continually be doing over winter, certainly as we head over weekends, where people can go to pharmacies and things like that. So there is a campaign, but take your point on board. But I wonder if the providers want to answer about the clinical places people are in the queue.
If I just come in from a UHNM point of view, Chair, so we've gone through a real validation exercise of making sure we've got appropriate contact numbers recently. So we've purchased a texting service where we can text out to everybody who's waiting over 78 weeks. That then produces us with a list of those that we haven't been able to make contact with. So we then use the more traditional home telephone number or letter. It is more difficult to say you are a number 134 out of 400. We try and give people a rough estimation of how long left they have got on the waiting list, but that is always dependent on what comes in. It's absolutely one of the weaknesses of currently where we are in terms of having such a long wait for services and making sure people are aware of where they are so that they can plan appropriately for life-changing events if they get married or going on holiday. Our long waits now are significantly reduced. We were in very early double figures rather than the very high hundreds that we were at previously, and most of those people that are now choosing to wait longer are because of life events, moving house, going on holiday, that sort of thing. But we're confident by end of October, beginning of November, that will be in single figures.
Thank you, Paul. Anyone else from within the system?
Shall I just comment on that? I mean, this is very similar from
Thanks,
an
Jenny.
MPFT perspective for community services. As Paul said, that we have done the work to validate our waiting lists and communicating with people on those waiting lists. Paul says it's difficult to say where you are in the queue, but to give people indicative waiting times for assessment. Once they've had that assessment, they'll be given timescales for intervention and appropriate contact numbers in terms of seeking support whilst they're waiting those interventions. But we don't have any waiters over 52 weeks across community services now, so very significant progress against our waiting lists, and in a relatively good position despite the particular workforce challenges that we've got and the demand that we're seeing coming into services.
Thanks, Jenny. Bernard?
Thank you, Chair, and thank you for those responses. It's a difficult listen, that is. It's really hard to listen to that message in terms of what the public are having to put up with. That's no criticism of the NHS, because I fully take on board the challenges that you have. But for Joe Public, and that includes me, that is a difficult listen, having such a big element of unknown around healthcare. Thank you.
Can I just also ask a follow-up to what Bernard was talking about? Can someone confirm whether we've got to the end of the people coming forward with delayed diagnosis, or have we got still some more to come?
So in terms of diagnostic position, I'll ask probably Paul and Phil to come in. So we've been improving across the board on all weights, but also diagnostics. There are some pockets of challenge. So what we describe as subspecialties, where, again, it's about workforce, so where we've got some workforce issues, but broadly, we've seen improvement across the board. But diagnostics, Paul, anything you want to add?
Yeah, so again, the workforce issue continues to be the main challenge around diagnostics, but we have secured additional CT scanning, additional MRI scanning on both the county site and the Royal Stoke site. Our biggest challenge in terms of being able to get a diagnostic test is ultrasound, and that's purely about demand and workforce. But for the large diagnostic tests for urgent treatments, cancers that we require on very heavily, we're back to a very good position compared to where we were during COVID. We're not quite at the position, we were delivering for example, the 6-week standard pre-COVID, but we've got a very good plan in terms of recovering that over the course of the next 6 months, training our own staff, recruiting our additional staff, non-qualified staff becoming more technically trained, etc. So in terms of our ability to diagnose, not where we were pre-COVID, but very much improved over the course of the last 6 months.
Yeah, sorry, that was probably my mistake in using the word diagnostic, wasn't it? What I was really meaning was in community, the people coming forward from within the community, seeing GPs, because that's obviously building demand still. Have we now got our hands around all of those people who didn't come forward during COVID, and are we now beginning to see the end of the peak? I guess I was really asking a population health question, I guess.
Yeah, so we've got Chris on the line. I think Chris Bird, who's Chief Transformation Officer. So it's work ongoing. So that sort of hidden backlog piece within society more generally is a really difficult piece to manage. It's not sure who said it, but the unknown unknowns piece is truly out there at the moment. So we can deal with what is reasonably visible to us, and I know that general practice are doing that, and we're managing across broader community teams as best we can. I suspect there is a continued hidden pocket of demand out there that it's very, very difficult, and this is a national issue as much as a local issue, very difficult to proactively manage that until it becomes visible through presentation, essentially to NHS or social care or other services. But general practice is really pressured, very, very pressured. But in terms of contacts, I think it's right to say that we're above pre-COVID levels in terms of the number of contacts that general practice is providing to the population. Chris, do you want to jump in there?
Yeah, thank you, Peter, and good morning, everybody. Yeah, so certainly in terms of the number of appointments that are available through general practice, they are now back to pre-pandemic levels, but we know there is still a lot more to do in terms of access. It is a real pressure point and part of a constant feedback from patient surveys and patient experience and so on. I think in relation to the specific question about have we seen the peak, I think we'd say we're still seeing sustained pressure on GP services, and often in common with other services, the complexity and the acuity of conditions and issues that patients are presenting with is generally speaking higher than pre-pandemic. So I think we'd say we're continuing to work through that higher than normative level of demand, both in terms of volume and complexity and acuity.
Thanks, Chris. Can I just bring in Tracy Shun in the room?
Okay, thank you, Chair. And I'm Tracy Shun, Director of Communications for the Integrated Care Board. We are running campaigns starting with breast cancer, moving on to lung cancer, to actually encourage the public to come forward more. So there's quite a number of communication campaigns that are going on and will be out there encouraging people, if they're concerned, to come forward. And you'll probably see them on the TV and things like that. So it's just a message out to the public if you are concerned to come forward. So we are sort of encouraging people, to come forward and get help if you need it.
Thank you, Tracy and colleagues. Keith Flander.
Thank you, Chair. And I don't know which order it was in, but anyway, thank you very much for all your answers and everything else in relation to staffing and all the issues around there. I'm going to try and move on to something slightly different. I noticed that you mentioned the idea of providing some sort of exercise in looking at flow rates of patients through both coming from the community and back out into the community. Have you done, what sort of analysis are you going to be doing in terms of flow rates between the various departments, as well as the input rate, if you like, and the output rate? And my interest is, what sort of, I don't know, influence, what control have you got that you can maybe support what we can be doing, which is within our own communities? To try and help you to try and reduce these flow rates, or try and make them so that people can get the services that they are. And the final bit of that is a bit about communication, is that once you've identified pinch points and everything else, which I think is the report that you're going to be bringing back to us, I do wonder whether or not you could use communications and other things to help that, to try and reduce those pinch points at the time that you have started looking and seeing this at the tactical level. So I hope you got that question and understood it. Thank you.
Peter, is that with you?
Yeah, I'll begin if I may, Chair, and then hand over to others. So on the one hand, the kind of the discharge process is simply queue theory. It's going from one phase to another phase to another phase, and as those phases start to back up, then it makes difficulty further down the line. So that kind of thinking about traffic going down the M6 and queuing, on one hand, it's no more complicated than that. Of course, the reality is if you add in the scale of the queue that we have, the complexity of population, the complexity of that UEC pathway, it becomes incredibly detailed and incredibly complicated, and that's why, you know, in the NHS, UEC is seen as one of the wicked problems out there, the sort of pinnacle problems and challenges that we all wrestle with and face. So the way to try and manage some of this, or at least how I try and think of wicked problems, is to simplify them as best we can, to break it down into bite-sized chunks that are manageable and understandable, and then work through each element and then attempt to bring it back together to understand how that operates in aggregation. So there are things that we can do as we go through that discharge review process to, as I say, simplify the situation as best we can. All elements of that process are relevant, aren't they? So in terms of management between departments, within organisations, whether that be within the ambulance service starting at the beginning, or within the UEC, UHNM's aspect of UEC, within MPFT, within local authorities, etc. All flow within those organisations is relevant, as well as the interfaces between organisations. One other thing I'll mention before I hand over to others who might want to pick out certain bits as examples is that nationally there's a flow improvement initiative described as the North Bristol model, which is because it was developed initially in North Bristol, you won't be surprised. And that essentially creates more of a push model than a pull model. So what that means is historically UEC has been as I described a moment ago, a pull model, in that when departments feel that they're ready for patients, they will receive and ask for patients to come to them. And that could be within an organisation or cross-organisation. That doesn't necessarily best reflect and understand the relative levels of clinical risk in all parts of the system. It effectively divides departments and organisations away from that clinical risk balance piece. So the push model gives more of an impetus of flow and asks receiving departments, receiving organisations to more proactively prepare for the receiving of patients from the previous part of the flow pathway. Now, for me, that makes a lot of sense. Of course, the clinical challenges associated with that, because it's a fundamental change culturally in how we would operate as a system, they're massive to get over those clinical challenges. I know that folks are working really hard to try and manage that, but it's an example of a different way of operating within the UEC pathway to try and break down those barriers and build closer relationships, clinical relationships between each aspect of the UEC pathway. So there's cultural stuff as much as there is the basic nuts and bolts, Q theory stuff, the M6 stuff involved in all of this. And that's fundamentally why it's a wicked problem that everybody nationally is wrestling with. Colleagues, anything specific that you'd like to add in terms of helping to describe how we're going about that evaluation process? Phil.
Thank you, Peter. Thanks. So, I mean, yeah, to build on your example of the M6, really, we see a blockage in one part of the pathway very soon feeds back right up the system. So, for example, if within MPFT reablement discharge to assess beds, we're struggling to move people on from there to long-term care placements. We then struggle to move people out of the acute hospital into those rehabilitation beds in the first place. And then we struggle to move people from the emergency department into the bed base because we can't move people through. And then similarly, ambulances are waiting on the drive because they can't get into ED. So what we see is very quickly, even quite a small delay or blockage or build up in one part of the pathway can ripple right the way through the rest of the pathway. The second point I just make is that we've engaged some external support as we're heading into winter, some external expertise who have come in and are looking at all of our data across all bits of the pathway in an attempt to give us a demand and capacity model with variables built in, so we can tweak things and say, well, if we had a bit more capacity in here, or if we take a bit out here, what will that overall effect be on the flow within the system? So we're really excited by the potential of that piece of work to be able to help us better direct our efforts and capacity. to make sure that we keep the flow, because UEC is all about flow, and it's all about all the partners coming together to deliver their individual bits.
Paul, we're with you.
Yeah, and I don't think we can underestimate the significance of that bit of work that Phil even has just spoken about, because it identifies how much activity we need to do, both elective and urgent care, because elective is as important as we've talked about because of the long waits at the moment. It looks at MPFT's activity to be able to support the community work, to support us from a discharges point of view, and it also will shine the light on the challenges that UHM has in terms of length of stay and simple discharges. So this one piece of work for the first time will pull together a number of strands that are data-based, good practice-based, which then allows us to have a really focused review of where we're going, to try and turn the dial slightly to make the biggest output for patients through the pathway.
Keith.
Yeah, thanks very much for that. Great answers. Thank you very much. I realise there's a lot of work to do. Hopefully some of that will keep coming back to us, Chair, in terms of the analysis and everything else. I'm just thinking, I think my closing comment, we all know when rush hour is. In my business, I don't travel on Fridays, and I think in your businesses, don't get ill on Fridays. So my point is that there are downtimes. There are things that we can do to take that pressure off the rush hour. And I just hope that you will start thinking about that as well. And hopefully that will also take pressure off the staff and the staffing issues as well. And hopefully things will get better. Thank you.
Thank you. Can I bring in Janice, and then we can wrap up this session if that's okay. Janice, and then we'll have Rosie, but and then we'll guillotine the session.
Thank you, Chair. My question is very similar, but not the same, hopefully, as my esteemed colleague here. I did wave first, but I'll let you off, that's fine. Specifically, looking at the initiatives, and I can see there's a raft of initiatives coming through, whether it's virtual wards, the medically fit for discharge, home first, a provider of last resort, is to look more so at the time frames from those. So I can see those, so looking at that through flow of things coming out, but when are we looking to see, some of the comments are about it slowly reducing, is to see when we're likely to, when that impact, is it likely to be there for the winter pressures in particular? Are we likely to see more outcomes from that? And then two specific questions on the way they come in, if I may, Chair. There's a comment about call abandonment, one of the least in the country. If we could have a bit more detail on that, that would be helpful, I think. And what do we think people do when they abandon those calls? And also the nature of admissions, the community approach for repeat admissions. Is there anything that we could be doing to support that community approach to encourage people to go to the right place first time, potentially? Thank you.
Who'd like to pick that up? Peter?
Yeah, so I can begin. Sorry, the first question, I was writing down the second and the third question in terms of call abandonment and repeat admissions. The first one was, just remind me again.
I think the first question was more about, could you provide us with a project plan of when the projects will start to have a measurable impact on residents and flow? I think that was, in summary, what was asked.
Yeah, so so all of the activities within the report are aligned to the winter planning work that we're doing. So essentially the expectation is that prior to winter kicking in earnest, in full, we would expect to have delivered the various initiatives. Their impact then on the effectiveness of the UEC pathway is, well, I wouldn't say it's in the hand of the gods, but it is very much predicated on, other variables within the system. But the implementation of those various initiatives we're doing prior to winter kicking in. So we can definitely provide at future meetings, Chair, if that would help, a summary of progress in relation to the implementation of the various initiatives. And I would imagine the performance dashboard that we'll come on to in a minute, but the performance dashboard will give an indication as to what the effect then of those causal actions and improvements will become. So hopefully that answers that first point. In terms of call abandonment, I don't know whether Mark or others in the system, perhaps Chris, would want to come in on that specific point.
Or Phil, you're talking about one. Oh, sorry.
Steve, oh, sorry, or Mark.
Yeah, I was just going to clarify the call abandonment does refer to 111.
Yeah.
But by way of what do people do, we know that they do a variety of things. Some of them do call 999. So it's really important that call abandonment is low, as is being reported in that report.
Steve, sorry.
Yeah, sorry, you're right. It is the 111. We're lucky in Staffordshire in that the call abandonment is very low. We've got the best performance for that in the West Midlands. But some of that is serendipity because Vocare have been able to reallocate a huge amount of resource from previous services they offered in the south and be able to focus that on the Staffordshire patients. So both the calls answered in 60 seconds is very high and our call abandonment is very low. So that's something that we should be celebrating really, and long may it continue.
Okay, thank you. And then repeat admissions. The one thing I would say, and I'm conscious that we've lost Paul, by the way, from the call now at UHM, but the one thing I would say about readmissions is that it's a fine balance to ensure that patients are discharged in a timely manner once medically fit for discharge. And of course, inevitably, given the focus on flow, discharge in a timely manner is critical to enable that we maximise flow. But at the same time, what we would not want to do, of course, is to discharge and then force a readmission because that discharge is too early. So it is a fine clinical balance that we look to achieve minute by minute, frankly, let alone day by day. Steve, do you want to add to that?
Yeah, so it's something Jenny and I are doing a piece of work on readmissions now. It's something we look at on a regular basis. We're just completing actually a readmission audit of those patients, particularly if they've gone through D2A and who've also gone through other pathways. But you're absolutely right. Most of these patients are frail elderly, and in the course of events, some of them will be readmitted anyways because of the nature of their illness or the health challenges they have. But you're absolutely right. It's something we keep a very close eye on and something that we need to always strive for to make sure we're assured we're doing the right thing by patients, but also not keeping them, the other side of the coin is we're not keeping them in hospital for too long, because the longer they're in hospital, the more defunctioned they become. So it is a bit of tightrope, but it is one we're very mindful of from a quality and a safety point of view.
Thank you, Janice. Thank you. Rosie, last one with you.
Thank you, Chair, and thank you for your report. Under winter planning, which is item 10 on the report, 10.2 analysis has been undertaken to understand the potential demand. Now it speaks about assumed non-elective demand levels 2019-20. Are we saying then that we're expecting that the demand this year will be the same as it was in 29-20? And if so, have we looked into the potential extra demands that might come to the NHS service in respect of people fearful of putting their heating on and potential illnesses, not just the flu and COVID, which I'm sure is a real thing for residents county-wide. Thank you.
Yeah,
Peter.
Yeah,
Thank you, Chair.
Yeah, we've got Phil and Steve, hands up.
Yeah, thank you. Just to respond to that. So in terms of the planning assumptions for winter this year, what we try to do is take a reasonable worst case scenario from a planning perspective, and then obviously we can all hope it's better. So when we look at 2019-20 winter activity levels, I think they were almost 5% higher than what we're seeing right now in volume terms. So it seemed prudent to plan on that basis, and then similarly building in the flu and building in COVID. I think the important point is what we're seeing at the moment isn't necessarily a numbers game, it's an acuity game. So we've really, the challenges we're experiencing are generally linked to acuity rather than raw numbers, if you like, through the door. So it's important that as we continue this work that we've been externally supported with around the demand and capacity, that we're playing in all of these factors, and particularly the acuity point, and obviously drawing in the comments you've made around general public health and well-being in the face of the energy crisis and things. So we'll continue to fine-tune that model as we go through winter, but as a starting assumption, we worked off the 2019-20 plus flu plus COVID. Steve, sorry, did you want to add anything on?
No, you covered what I was going to say, Phil.
Rosie.
Yeah, that's fine, as long as we know that it is being looked at on and reviewed based on what is actually happening. Thank you.
Yes.
Okay, thank you. Just can I pick up a couple of things? In terms of the answer to the question from Janice relating to project delivery, yes, I think it would be really useful if you were happy to bring back updates. Don't always have to be in person. We can do some written ones from time to time. But I think this is one of the top issues for residents within Staffordshire. And obviously within the system, you know, we have representatives from across the whole of the system. So I think bringing back those would be very useful, please. I didn't get to ask my question, so I'll leave it on the table, but I will leave it there, and I will pick it up separately with you, which is I just want to challenge the whole of the system whether there are opportunities to bring other partners into the system to help you out. So, for example, could the fire service play a role to help the ambulance service out? For example, are we using the end-of-life pathway where appropriate to its fullest extreme? Probably the wrong word there, to its fullest level. And are we looking at those frequent people who are admitted into hospital from, say, care and residential homes, and ensuring that we apply maybe a regular visit, which then alleviates the need for them to be conveyed to hospital? So I'll leave that as a question on the table for people around the table. I will come back to it. But otherwise, I think we're asked to note the report. I think we should note the report and also just acknowledge that it's a very difficult time for all involved, whether that's residents or staff, and appreciate clearly the work that's being done to try and improve the flow through and to mitigate and minimise the impact on not only residents but also the staff involved. Is there anything else that people want to add as part of that update? On that basis, I'm getting nothing else from within the room, so I would thank those colleagues who are have contributed, and let's move on to item number 5, which is the Integrated Care Board Performance Update. Are we with you, Phil or Peter?
So I think you start with me. I'm conscious I've had a conversation offline with Tracy. I'm conscious of the committee's time. So and this presentation is quite a lengthy one. So our suggestion is if I hand over to Tracy in a moment, Tracy sums up the narrative, the detail from within the presentation, and then maybe we go straight to Q&A. We have got additional system personnel on the call now. So we've got Heather Johnson, who's Chief Nursing Therapies Officer at the ICB, Lorna Clarkson, Deputy Medical Director, to name a few. So additional folk have come on to participate in the Q&A process. So if that's okay, could I hand over to Tracy in the room just to sum up the key sort of updates, as it were, within the report, Tracy?
Yeah, that's perfectly fine from my perspective. Just for members, I'm going to take this page by page. So whilst Tracy's talking, please can you formulate page by page what you want to pick up, because it'll be the quickest way. Tracy.
Okay, thank you, Chair, and thank you, Peter. We did have a slide deck for you, but I think it's 20 slides long, so I don't think that would be appreciated by anyone this morning. So just to introduce the paper, as far as the integrated care system and the integrated care board, in the way we've organised ourselves, we've actually organised ourselves into portfolios based on priorities, which are in your paper. We've got population health, planned care, and I think we've touched on planned care earlier in the earlier conversation. Children and young people, urgent and emergency care, which we've just covered, frailty and long-term conditions, primary care, and mental health, learning disabilities and autism. As part of planned care, I do include cancer with that. The paper does take you through each of those in turn. So starting importantly with population health, prevention and health inequalities, and we've heard from the committee this morning some suggestions around that. Also going into planned care, you'll see around the 104-week waiters. You'd heard from Paul, by the way, how they were working on that, but obviously there's more within this. And in terms of cancer, again, diagnostics, have touched on that already this morning, but there may be further questions that you would like to ask on that. Heather Johnson is on to talk about maternity. Maternity is a particularly pressured area at this moment in time, and we are really challenged around the workforce and around midwives in particular in that area. And frailty long-term conditions, anyone who was at the ICB board will have heard quite a discussion around that, because it's obviously one of the key areas, and I think people that we see admitting to our services that we need to look and try and keep out of hospital as much as we can. Long-term conditions is something that we always have been focusing on, and how people can help manage their long-term conditions. But I think some of the things that you get challenged yourselves as counsellors is probably around primary care access. You've heard this morning as well that GP contacts are back up to pre-COVID levels, though we still hear issues from our community around access on that. I've got Ben with me in the room around mental health, learning disabilities and autism, so I'm sure, Ben, you will answer any questions within that. But as you can see from the paper, mental health, we're seeing quite a number of people coming forward now, and with some severe mental health issues as well as well-being issues. I'll stop there, Chair, because the paper does go on. I mean, we have talked about workforce, and we have covered a number of those issues that were in this paper. But there's a number of people on the call for you, and I'm sure some of them are challenged to have to go to system calls as well that they have to do. So I'll shut up and hand over for any questions.
Thank you, Tracy. And no doubt you'll circulate those slides in their fullness. So I'm going to propose that we take this page by page, because otherwise we'll dot around the place and risk missing the questions that people want to pick up. So currently I'm on page 32 of the report pack, and I'm looking around to see if anyone is going to pick up a question on page 32. I'm going to turn on to page 33. You'll have to ask a question at some stage, because otherwise I'll be very disappointed that we've changed the way we scrutinise. Okay. No, yeah, that's fine. Thank you. So I've moved off 33 and I'm on to 34. Now I'm on to 35. I'm going to go on to 36. We're going to see if I need to take my shoes and socks off, aren't we, to be able to count. Janice?
Yeah, I'm hoping I'm not... I was always rubbish at bingo, which is why I don't play bingo. So I don't know if I've missed my page now, but there was a mention about a text reminder service in one of the areas. I think it was colorectal action. Yes, it was colorectal actions. Is that something that is done across the piece, but it's just actually being highlighted in this one? And are we sending that text reminder service because there's a problem with did not attend, with people forgetting them? Because I can imagine that could be a problem in other aspects of treatment than others. So the question is that text service something that is across all of the services? It's just that it's only mentioned in that one. And are we doing it because people aren't turning up, or it's a helpful thing? Thank you.
Thanks.
Yeah, so I can begin if that's okay, Chair. So I think all of the providers now, to a greater or lesser extent in the system, do operate a text reminder or text support service to patients on waiting lists. How much that is rolled out, i.e. whether it's in every specialty within every organisation, I think perhaps the providers are best placed to be able to advise on. The purpose of the exercise is essentially, as described there a moment ago, to reduce DNAs, but at the same time, of course, it's good practice, isn't it? It's another way to communicate with the population, the position, a reminder, etc., etc. So just as the private sector do a lot of this, it's good practice within the NHS and within healthcare. We can find out outside of the meeting, if that would help, Chair, just the level of rollout of text messaging and reminder services across providers. Conscious Phil's got his hand up as well.
Thanks, Peter. Yeah, just to add to that, it's my understanding that we do seek to do those general reminders where at all possible, but the specific case of this was around the colorectal pathway, and obviously you'll see the levels of backlog we've got there. So this is about just absolutely making sure all of the capacity we have earmarked is utilised, so doing everything we can to provide additional reminders to patients at various parts of the pathway to ensure that they do arrive for appointments or indeed cancel if they're not able to make them, and therefore our clinicians' time is best spent. Thanks.
Janice?
Yeah, I think it would be helpful to see if it is consistent, because I think it would be extremely helpful as a patient, as a reminder, and definitely best practice to see if that happens. Thank you.
Yeah, and I think sort of building on Janice's point, I think the other element would be, does it go right the way through the health and care system, right the way from primary care, and is this a commitment from the system that, you know, residents are going to get a common customer journey, so to speak, which also does include care, because in the end, you know, the key should be in the title, integrated care system, and if you get different expectations and different delivery, then it doesn't seem to meet that element. Okay, Bernard.
Just in terms of the reach of these messages, in East Staffordshire, colleagues will have heard me say many times, we have some very, very diverse community, in excess of 26 different languages, and I think it's on the increase. Can you be absolutely confident that you're reaching these people? They may get the message, do they understand it? Are you able to accommodate those sorts of challenges? Thank you.
So yeah, Tracy might want to come in from a general comms perspective in terms of reaching local populations, particularly as you describe it there, Councillor, those that speak different languages, non-English is not their first language. I think wherever possible, we do provide different language services to individuals. I know that occurs within hospitals. I do think that occurs in terms of communications as well, whether that be digital communications or written communications. Can we be absolutely confident that we're reaching everybody in the right way? I don't think the answer is yes. I don't know that the answer would ever be yes for the entire population down to the last person. But reasonably, are we doing what we should be doing? I think broadly, yes, but let us take away the question about the diversity and breadth of communication means, particularly in terms of different languages spoken. I'm sure that between us, maybe myself, Tracy and others can understand precisely what's going on, particularly maybe if we just focus on the east of the county as a test bed.
Thanks, Peter. Can I bring in Tracy?
Yes, thank you. And we've learned quite a lot during the vaccination programme about how we do reach people from different communities. And we thank the communities because they've actually helped us, and that's what we need to do. We need help from community champions, faith leaders, and they've all stepped up and helped us with that. So it is something that we are focused on. As Peter says, it's not just different languages as well. It's other people that we need to access. We've had to access people who are transient through the county, and people who come here as seasonal workers and different things like that. So we've learned quite a lot through COVID. Will we ever stop learning? Probably not. But take your point, and I do know in East Staffordshire, certainly working with a number of community champions who help their communities raise issues and take their health information away.
Bernard, anything else?
No, I'm fairly reassured by that. I look forward to seeing it unpack over the next 6 months, and thank you, Chair.
Thank you. Can I just ask a question on page 36, which relates to maternity? I note that there is a plan for the freestanding maternity units to reopen. Are we still in line on Samuel Johnson for a reopening in December, which is what I think was in the minutes previously? And can we have a date now rather than TBC for Stafford, please?
Heather might want to come in on specific points in relation to the pressures that we've currently got on maternity services, and Chris may then want to come in perhaps on the specifics around those areas of service, particularly in terms of the East. Heather, maternity more generally.
Yeah, thank you, Peter. Thank you. I've been before actually, and I think most people have heard the story about maternity and particularly those issues with the freestanding midwifery-led units. The two we're specifically talking about at the moment are the one at County and the one at Samuel Johnson. As at the last local maternity board, there hadn't been an update from UHDB with regard to Samuel Johnson, but they are under extreme pressure at the moment, and I wouldn't want to stand here and hand on heart say I'm confident that the December reopening to the full extent will happen in the way that we would hope. In terms of the TBC, and I know it's a loose term, we shouldn't really use it, but in terms of the county hospital freestanding unit, I think it's safe to say that at this point in time, it's fairly certain they won't reopen in December, and though we're doing everything we can to ensure that services are offered in different ways, and we will continue to work with our providers to make sure that the choice requirements are made. At the moment, the staffing pressures facing maternity services are so great that there is very little likelihood of that happening in December. Just to illustrate that point a little bit further, and without going on and maybe talking about too much detail, there was a particular challenge at the end of last week where UH&M's main maternity unit, so the big unit up at the big hospital, was under so much pressure. And to make that real and to put numbers around it, a normal shift on a Saturday, you'd reasonably expect 12 qualified midwives in addition to support staff to be there. At a point on Friday, they were looking at 5 staff available to work that unit, which obviously presents a great challenge in terms of the safety and quality of care being provided. And we were working as a system, or we continue to work as a system, as we always do, particularly using our workforce team colleagues to get mutual aid and bring people into support. But that's in the main unit, that's not in the freestanding midwifery-led unit. Ultimately, unfortunately, that unit did have to temporarily close over the weekend, but that was about safely managing the people that were already there and making sure that anybody who went into spontaneous labour was diverted for a short time to a suitable alternative where there was sufficient staffing that delivery of a baby and the well-being of mum and dad, of course, and family could be managed safely within a normal maternity environment. So I think a lot of detail in there, but I think probably the short answer is unlikely at this stage, but we will continue to monitor it. If things improve and staffing numbers continue to improve, then that will be revisited, but that will be done as part of the ongoing review of the quality impact assessment. I'll probably pause at that point, a lot of information in there.
I think Janice wants to take over my question, so let me bring in Janice.
Yeah, thank you, Chair. That was definitely one of my questions in terms of, obviously, as the County Councillor for Lichfield City North, Samuel Johnson is a particular interest, and I had requested previously if there was any change, if we could be kept updated, because we certainly do have residents who get in touch and are desperate for it to open again, but I fully appreciate the first bullet point in there is about safe staffing, and that example that you've just given to go from 12 down to 5 is something that I think, would actually, well, it did make me go cold, just the thought of it. In terms of that staffing on there, is there any information that you could give us as to, is that just a temporary issue with staffing? And how are we likely to make sure that we are going to get that staffing? I'm not trying to anticipate the workforce one, so just a small update I think will be helpful. And definitely that a request again is that if it isn't going to be December, if you could advise us, so that, you know, that would be really helpful. Thank you.
Can I just intervene there, Heather? I think you're on our agenda for the 17th of October. I'm hoping you're going to nod.
I'll nod anyway, because I'm sure if it's in my diary, then it will be.
I like it when people are complicit. It's even better. So what else can you promise me today then, just by nodding? It's good. So can we, Janice, with permission, take that question in 2 weeks' time on the 17th, when Heather may have a greater update? And can we just also acknowledge the pressure on staff within those situations? Because I think we've all been in positions ourselves where, frankly, you expect more people around you, and actually there's a huge pressure on the staff involved as well. Janice, last comment on this one.
Yeah, if we could just have a quick response to the issue that was mentioned to go from 12 staff to 5, if that was temporary.
Yeah, I can just very quickly just tell you that that was in direct response to sickness, to staff sickness. So it was temporary. And I will add, although I'll give you more detail in a couple of weeks' time, that there is a significant recruitment programme going on, and that has been quite successful. So there are a number of staff starting imminently. So we'll go into detail on the 17th.
Thank you, Heather. And I think we've got to probably also try and elevate staff to being a strategic issue, and which requires a strategic resolution, because, you know, the danger is we're missing the whole point, which is, you know, all of the system is under pressure, not just one point of it, in my view. Right, I'm still on page 36. I'll take any further questions on page 36. None indicated. So let me move on to page 37.
40.
No, I'm still on page 37. So let me ask a question if no one else is going to. I was a bit surprised under the actions of 12.5 and the first point, the frailty plan, that for a scheme, for a plan that was produced and signed off in 2020-2021, there wasn't an implementation plan already created. So that did surprise me. And the second question I'd got relating to the actions is, does the plan involve allowing people to die with dignity in a place of their choosing?
Yeah, so if I start, and others I'm sure would be happy to contribute. So we are, just to take it back a step, we've relatively recently signed off a different operating model within the system, and what we're doing is concentrating on delivery through what we call portfolios. So we have 7 portfolios now within the system. UEC, not surprisingly, is one, which links to the end of life position you mentioned a moment ago there, Chair, but frailty and long-term conditions is another. So having recently, within the last couple of months, signed off that different operating model, what today, in fact, we've done is to launch a staff consultation, for example, for across the whole of the ICB team, 300 plus staff, to adjust, to tilt that operating model and to change how we work across all of those staff, focusing on that point, those 7 portfolios. So this is significant change, and I would argue improvement in how we'll work. So that change enables us to focus more heavily from a performance management, from a capacity delivery point of view on those areas, frailty being one of those 7. So it's difficult for me to speak about how the CCG and system have operated prior to the 1st of July, as you can imagine, Chair, and others, given the fact that we weren't established until then as an ICB. But rest assured that the frailty agenda as of now is taking front and centre stage, as I say, whether it be through those 7 portfolios being one of those, or the fact that the board at the ICB recently, only a couple of weeks ago, heavily discussed the frailty agenda, actually the frailty strategy, and if there was one needed, gave the green light to move forward with the frailty plan. The end of life programme, again, in my view, maybe hasn't moved as far forward, and taken the opportunities available to it in terms of that preferred place to die, for example, agenda, massively important to individuals, family, and has a huge knock-on effect, if done badly, of course, to the population, but a positive knock-on effect, a massive positive knock-on effect if done well across the population. That agenda is being managed through that frailty and long-term conditions portfolio as well. I recently met with Chris Bird, with one of the chief executives at one of our hospices, and had the conversation about how we move that at pace, ensuring that the flow processes, everything we've talked about over the last hour, is done in such a way to mean that individuals' effectively final requests are appropriately delivered and met within the system. So that work again has ramped up the end of life programme that sits within that last portfolio. So absolutely all really important things. And I'm sure that through either board conversations or that reorientation of the operating model within the system, we're going to make sure that these hugely important things are delivered effectively and in a timely manner, Chair.
Thank you, appreciate those. Let me bring in Janice.
Yeah, it's moving on to 14.1, Chair, if I can, on performance for general practice. 2 questions. One where we look at 2/3 face-to-face. Is that patient request that is determining the level of if it's face-to-face appointments or alternatives. And then the majority of practices, is that 51% or closer to 80-something%? How much of a majority is it? And are we looking at encouraging all practices? Thank you.
So, Chair, Chris might be able to come in with some of the detail. Whether he's got all of the detail to hand, I'm not sure. But Chris, in terms of that face-to-face piece and encouraging practices, but also individuals where relevant to meet face-to-face a GP, thoughts on that, please?
Yeah, so if I just talk about access in more general terms, and I'll pick up the specific points. So the challenges around access, which as we talked about earlier in the session, we have kind of got back now to a level of appointments being offered that is pre-pandemic level. So that's roughly equates to about 400,000 per month across the 143 practices that are in Staffordshire and Stoke-on-Trent. The majority of those in Staffordshire. But the challenges around access are essentially products of two factors. One is around workforce and one is around workload. So workforce, about GP recruitment and retention, we know we've got challenges in that regard. We've got a range of initiatives to bring and attract new GPs into our system, to retain the excellent ones we already have. We've got a number of schemes that are called ARRS roles, which augment capacity at primary care level. So we've got about 350 colleagues who deliver those ARRS roles. So that's things like advanced practitioners, first contact physios, social prescribing colleagues, for example. We've got some initiatives, innovative initiatives underway, things like digital GP locums. So that adds to the ability and the flexibility of GPs to be able to augment some of the access issues we've got in terms of availability. And our primary care team work really proactively with some practices which we know are having some particular difficulties, to make sure that they can continue to operate, continue to function, and continue to offer care for patients. On the workload issue, and then I'll pick up the access, the face-to-face question as part of this. As I say, appointments back to pre-pandemic levels. We've talked about complexity and acuity in terms of presentation, and that continues to be an issue. We do have a mixed economy of access. So as we say, about 2/3 now are face-to-face. Some of that is patient initiated. Some of that is based on clinical assessment by the GP or other clinical colleagues in terms of how best that patient should be triaged and seen. We've also got supporting schemes like community pharmacies, offering same-day urgent access for conditions or complaints that can safely be seen in a different environment. And we've got a range of digital-first primary care support offers, so pulse oximetry at home and blood pressure monitoring at home. So we're not complacent. We understand that access is a real issue. As I say, it is a constant piece of feedback in terms of patient experience. So more work we need to do, but I think in response to the two kind of causal factors around access, we've brought forward a wide range of measures.
Thank you, Janice.
Yeah, I think the other part of the question, appreciating what's just been said, was looking at those that are offering same-day urgent appointments, and I think it's consistency, because there are some practices maybe that will only do one type of appointment, and I think some of that is the flexibility that also would be helpful for the patient, obviously, as well as for the practice. But in terms of getting those same-day appointments, how much is it the majority that are offering it, and is the aim that all practices would?
So there's probably a design feature of some of the contracting arrangements that play into this, if I may. So generally speaking, all practices will have a same-day urgent offer access. Now, I say that in the knowledge that many of us will have had the experience of trying to get through to our practices at 8 o'clock in the morning, and that's often difficult, and we understand that, and that's part of the feedback we get back from patients. But the vast majority of practices will offer same-day urgent access appointments. There are some instances, perhaps with a branch practice, where one branch is being used specifically for planned care appointments, the other is being used for for urgent access, which is why it's not kind of 100%, but the vast majority will offer same day urgent access. There is, though, a support offer that's called enhanced access, which extends GP appointments from about 6:30 in the evening through till 8 o'clock in the evening. And that's contracted at PCN level, so primary care network level, which is group of practices working together to offer that same day appointment. So in that respect, it's not necessarily true to say that every practice will be offering that extended access, the enhanced access offer, but that's a kind of construct of the way in which that particular offer is designed.
Okay, I think that moves us gently on to page 38. Sorry, Bernard.
Thank you, Chair. 13.2 performance. I'm looking at bullet point 3. Increased number of referrals made to the Diabetes Prevention Program each month. The referrals, someone living in East Staffordshire being referred to Birmingham doesn't sound right, and I know that that's been happening. So is there a peripheral boundary for referrals from where the question first starts, or is it just wherever the nearest vacancy is? Do you have any regard for people having to travel to undertake this assessment?
Chair, could I suggest we take that away? I don't have that detail. I'm not sure others on the call will have that detail down in terms of the management of the referral process for that specific service.
Delighted. Happy to have a written response when you've got that information. Okay, let me move on to page 38. I just wanted to ask probably Tracy a question which relates to the first point, which is about community pharmacies. How are you going to communicate the availability of community pharmacies to residents? Because if you don't tell them of the change, frankly, they'll carry on doing what they're currently doing because they're none the wiser. And the whole point is to open up capacity in primary care, I would guess.
Yeah, I think there's a big thing about the changes around general practice that we need to communicate out to our public, and there is a piece of work that's underway actually explaining things around the different people you can see at your practice. We've got videos and different things we've done to show how people can see. You might be better seeing a physio, etc. So in terms of community pharmacists, that will be part of that programme. So it's a programme of work of, I don't want to say educating the public, but actually helping the public understand how the changes in general practice have been made and how actually they can access them and better and probably in a more timely way as well. So that is something that's ongoing, and it is a campaign that we are continuing to run around primary care.
Thank you, appreciate that. Mike.
Thank you, Chairman. Just on that point, there may well be a part that districts and boroughs can play in delivering that message as well, and certainly we'd be able to put that through our systems and the way in which we communicate with all our residents. So if that can be made available to us as well, we could perhaps play a part in delivering that message as well.
Yeah, we develop toolkits, and we do work with your district and borough communication colleagues. That they've continued all through COVID and onwards to work with us together. So what we do is do toolkits that we send out to them to help them get out to communities. So I'll make sure that they distribute round to yourselves as well. Thank you.
Thank you. Anyone else on page 38? Shall we move on to page 39? Jill Hood.
Thank you, Chairman. Page 39, 15.2. Mental health practitioner roles continue to be extended in primary care. I realise that during the pandemic we had a lot of telephone services rather than face-to-face. But Tracy, you've just spoken about seeing people within our primary care system. Yeah, you can see people, but it seems to be that the mental health access for most primary care surgeries are actually telephone conversation, tick box exercises. And it's my belief, speaking to people, that people with mental health issues are becoming isolated. And I'd like to ask yet again, how are you measuring the success of the telephone conversations, tick box exercises What's the feedback that we have, please? Thank you, Chair.
Yep.
Okay, I can begin with that if that's okay, Chair. So there's something about needing to take that away, I think, and to understand how we're evaluating the success of those of that way of operating. I don't think that any of the services that those guys offer would be, well, they would class them as tick box exercises. I presume that the questions being asked as part of those consultations have been developed clinically. I would hope that they've been developed clinically to be able to understand certain clinical indicators, etc., and then be able to signpost to other services if needs be. But it's a fair point from the perspective of we need to ensure that every single contact counts and is meaningful and does what it needs to do in the moment. So if we could take away the question with regards to how we're evaluating the effectiveness of those general practice contacts in relation to low-level mental health conversations, then we'll bring back whatever we can at the next available session, Chair.
Thank you. And I'm just aware in the room we've got Ben and possibly even Tracy who might want to just add.
So as Peter said, we can pick that up. I suppose it's just to add that as part of that ARRS model that Chris mentioned earlier, mental health is part of that, and each PCN does have a physical mental health practitioner based in that service, but they will adapt how they deliver that service based on the need of that local PCN and working with those local GPs. But I just wanted to add as well that from a combined perspective, we've been monitoring with our services telephone versus face-to-face delivery as we come out of COVID. And we have actually adapted some of how we do our telephone consultations anyway, partially because even though they may be appropriate from a clinical perspective, what patient feedback has told us is that when we've asked them questionnaires in another environment about have you been reviewed by a clinician, patients have answered no, because it hasn't felt that way to them. And so where a telephone consultation may remain an appropriate clinical tool, we've adjusted how we do it so that it also feels that way to the patient. Because if it doesn't feel that way to the patient, even if the clinician's happy with it, it's a bit meaningless. So there has been some learning and adaptation for those where a telephone consultation will continue to be used.
Please.
Thank you. I am delighted to hear you say that you've asked patients if they've been consulted with, and the answer is no, because that's the feedback that I get. I'm going right back to a very naive statement. If someone comes to me with a broken leg and says, I've had a telephone conversation, then I'd know that they weren't telling me the truth. But someone with a really complex mental health condition being spoken to on the phone, we know the degree of mental health, the variety of conditions of mental health, they're not always adaptable to a telephone conversation, and that greatly worries me. So I'm very pleased to hear you say that and realise that there is a full understanding that telephone conversations really shouldn't be held with people with mental health issues. Thank you, Chairman.
Does anyone want to come back, or should we just handle that through anything further through written? Ben?
Yeah, I think it would be easier because we could also include some of, I need to check with MPFT, but we're monitoring the shift between telephone, video and physical as well. But in some cases, it's not completely inappropriate. For some patients, it's the right thing, and that's what they tell us that they need. But it's that balance between a very COVID response of we have to change immediately now to working out what's the new normal.
Thank you. Let me bring in Councillor Anne Edgeler.
Thank you, Chairman, and thank you for your presentation. My question, relates back to mental health, and I agree with everything that Councillor Hudds has just talked about. But on page 39, on item 15, mental health, the programme continues to receive extremely positive feedback. But we all know that mental health is on the increase in all ages, and I'd like to know whether we are increasing staff within the system on for mental health, you know, to make sure that we can cover all aspects of it. And I'd like to know what situation is regarding the CAMS service as well for children. And also, Are you speaking at government level for more money and input into mental health? Because I have a feeling that sometimes we're not receiving the amount of money we receive to be able to give patients the service that they require. And also, can I, Chairman, with your permission, can I also move on to page 40 because it relates to mental health?
I've got a whole stack of people behind you who want to
Okay.
ask questions on
All
this
right
page,
then.
please.
So can I have an answer to those questions, please?
Ben, Chair, if I may, Ben might be best placed to answer as SRO for the mental health programme more generally in terms of that workforce piece. Ben, is that okay?
Yeah, so you know, like all the other schemes, we have challenges around workforce, and that's in general. There are a number of national and regional and local schemes where we're diversifying our workforce, looking at new roles and working with a number of universities, including Keele, to move that forward. That's not to say workforce doesn't remain a challenge. In a way, though, in mental health and Autism, it's also a bit of a nicer challenge, because part of the reason we have some of the workforce challenges is the investments we've been making. So as the scheme refers to, and members may know, that we have what's known as the Mental Health Investment Standard, and that's a ring-fence pot of money that can only be used on mental health. And that's, if we're honest, is in a national recognition that investment in mental health hasn't been where it needs to be in the past, and that urgent pressures elsewhere may pull away that money. You'll see in the report we refer to investments we're making in eating disorders, and even in the last month as a system, we've agreed to invest next year £1.6 million across Stafford and Stoke-on-Trent into perinatal services, and because we recognise that the service that we're giving to pregnant ladies and those who have recently given birth is not where we want it to be. I'm never going to say I've got enough money, because I always want more, but I think we've got some really good step forwards, and mental health is always going to be a challenge, and we're seeing that after COVID, but compared to many other systems around us, we are doing well, but we recognise there's still a long way to go. In relation specifically to CAMHS, it is an area of growing demand. However, access rates are improving. Again, we come to some staffing challenges in some specific sub-areas. There is a challenge, but we are definitely seeing the impact in those numbers as people come out of COVID and isolation.
Thank you for that, Ben. I think one of the big gaps here is that we haven't been able as a committee to really talk in detail about mental health because there isn't a mental health strategy, which we seem to have been waiting for a long period of time. Before I bring in Anne, I'll bring Anne in 2 seconds. Can someone give me an indication as to when this joint mental health strategy will come forward, please? Anne, do you want to just ask anything following up?
I just want to make a comment, please, and that is, please remember that mental health is just as important as physical health when you're making decisions. Thank you.
Can I just come in?
Not...
I've just completed a mental health and wellbeing in the workplace level 2 course. I recommend it to anybody. I don't know whether anybody's had one of these offers of a free course, but I did it last month. And through August, and I have to say there's a distinct difference between mental illness and mental health and well-being, and they get confused. But the other bit is that I recommend people to do it, because while I was doing the course, I recognised in several people that they were starting to suffer from mental health problems, and it was affecting their well-being in many ways. And particularly in my day job, farming, there are currently 3 suicides a week of farmers who can't cope with what's going on. So that was the reason I did it, so that I can help people in my industry. But expecting the NHS to help somebody out who's a lone worker out in a field, who the bank won't lend money to because he's got £3 million worth of assets, but his income is 10 grand a year, and he's got bills coming in of £30,000–40,000, and he can't afford to feed his chickens, his cows, or whatever it is. They need somebody who's a friend on the ground to help them
go through the process and get the proper advice that they need, not just for the mental health and well-being, but also for the business. So I recommend anybody that go and do the course, and then you'll understand what you're talking about.
Thank you for that intervention, Philip. And I think it really just undermines the point I've just made, which is actually I'd like to have had a wider discussion on mental health, and it's probably not one for today. But we need the strategy to have the discussion against. So maybe we'll leave that question where it sits, and you can come back to me at some stage on that, providing it's not in 2023 or 2024. I'll bring in Rosie. It's Charlotte first, sorry, and then Rosie.
Thank you. I'm particularly interested in the so-called transformation of community mental health services for adults, because what I'm seeing is actually the closure of community projects. And I'm glad to see that there's extra investment, but all I see is disinvestment. Because it seems to me that we have a situation where you can go to your GP or you can go into acute care, and where there is a community projects, and there are community projects all over the country which are doing fantastic work. We choose the clues that closed down Nivden, because what they did was basically say to the existing clients, you've got 6 weeks and then you've got to go somewhere else.
Charlotte,
nowhere else to go.
Can I just ask which paragraph you're relating this to? Because we are really tight on time today.
Transformation of mental health services. I'm asking about where that investment's happening. And also I want to know about the jargon here. It talks about all investments related to the mental health investment standard and NHS long-term plan ambitions for mental health continue to be implemented. I really would like to know what that means, because for me it just means jargon, and I'm looking for what it actually means.
Can I make a suggestion just in terms of the time we've got and the agenda we've got in front of us? I'm going to suggest that we try and prioritise the mental health session within the agenda of a forthcoming meeting, because I'm not satisfied that we're going to cover this in 2 or 3 minutes here today, unless you have a different view.
I think that if you have a report presented to this committee, that they put a whole lot of jargon in, that we actually should know what that means. Just the basic, what the hell does this mean? Because, we've heard earlier that we've got, he's really pleased with new investments.
So I've understood the point. You just want a definition of what the jargon means, and I'm going to pass over to Ben to hopefully do that. And then I am going to suggest that to committee that we do take mental health as a separate subject, because I think there is enough demand around this table, and frankly, we're just going to scratch the top of the surface, and it's not going to be robust enough. Ben?
Yeah, so just in relation to that specific point, so it refers to the ring-fence pot of money I basically mentioned earlier. So the mental health investment standard is a ring-fence placed around some money to ensure that it's only spent on mental health. The previous CCGs now the ICB is specifically audited to make sure that that money is used in that way. So when we talk about that standard being met, it's that money has been spent on mental health.
Thank you. Can I bring in Rosie, and then we will move off this page. It's been interesting.
Thank you, Chair. And yes, I welcome your suggestion that we have a longer debate on mental health at a future meeting. My question just relates to 15.21, the Mental Health Wellbeing Hub. It talks about additional clinics. Could we have some info about where these clinics are going to be?
So I suppose just to give a little context on this. So the staff mental health wellbeing hub was put in over COVID, and we've continued it largely around the challenges we've already faced. So the pressures on our existing staff, how hard they're working, the pressures they're feeling. So the clinics, I can't give you the specific details here, but I can follow that back. But they respond to demand. So we have, as you would expect, a large presence on our acute partner sites, UH&M, etc. Actually, the mental health providers are quite high users. So they're in various places because they're, and they can be in a very disparate place because they're not patient-facing in the way they're accessed by staff. But I'm happy to provide, as a follow-up answer, specifically where they are.
Could you send that through Debs, please, and then we'll circulate it to all committee. Rosie?
Just to add on to that question then. So are these permanent hubs, or are they temporary hubs, depending on demand?
So there are some permanent sessions that are there all the time, and the ICB, like I say, is just committed to continue funding to that. Some of those extra clinics are dependent on demand.
Thank you. I'm now on to page 40. We've got 120 to do, so...
I'll be very quick, Chairman, thank you. And it's just to say to the people that we're talking about mental health, but when you come back and we have this session on mental health, you're talking about mental health support teams in schools. Can you please embellish on that in the meeting we have about mental health? Thank you.
Noted, no response required. Okay, anyone else on page 40? Right, let's move on to 41. Deathly hush, 42. Hey. Right, page 43. Lots of red. Not easy for someone who might be colourblind, I have to say. Albeit you could probably do it by exception on this one. I did want to ask a question on this. Does anyone else just want to come in on this before I do ask the question? Not getting an indication. And this is probably a Chris one, unfortunately. If I look at the table, which is 2/3 the way down, which starts time between booking an appointment and getting an appointment. You know, in broad terms, the bottom 4 indices, I'm not worried about the unknown data, obviously, but the 15 to 21 days, 21 days to 28 days, and more than 28 days, are all going in the wrong direction from the view of the stats that I can see. So that seems to suggest to me that, you know, there is a rook of people who are waiting significant periods of time to get an appointment in primary care. We've obviously talked a bit about primary care, but can you confirm there isn't a nub of people who are significantly disadvantaged, who are in this long queue, long tail?
If I may, Chair, there'll be some detail that sits beneath those, beneath that analysis. So if I may provide a written response, I think that'll be more conducive to me getting you a comprehensive answer.
Appreciate that. Thank you. That's helpful. Does anyone else want to pick up any of the data? Janice?
Is it okay for me to go into the next page, Chair?
You can.
There's still a little table on it.
Yep.
Yeah, it was looking at the comparisons there for the accident and emergency, the 4-hour targets and the 12-hour trolley breaches. We've got some pretty big differences in between the 12-hour trolley breaches in particular with the local providers, and I just wondered if there was some comment available to maybe explain why those differences are so great. Thank you.
Yeah, Chair, may I just jump in, conscious that we've lost most colleagues, and particularly those H&M colleagues that perhaps would have been able to add to this. What I would say is that each of those services has very much local circumstances that are unique to them. So if you take, for example, Dudley Group, Russell's Hall, that's surrounded by 3 or 4 other A&Es in close proximity, appreciating that, of course, the Black Country in itself is a large conurbation, large complex conurbation, but it does have a number of other A&Es in relative close proximity, and of course Birmingham just down the road, relatively speaking. What I would also add is that Royal Stoke is a trauma centre, one of the national trauma centres, so it receives patients by helicopter. So there are unique circumstances in relation to each and every service that creates a level of variation. And of course, that's accentuated by the conversation we had a moment ago in terms of UEC flow challenges specifically, which are creating differences across the board. The one other difference for the Black Country specifically is that they have what I describe as vertically integrated services. So the community services are integrated with the acute, that in some regards is beneficial, in other regards it's detrimental, but perhaps in UEC flow terms that provides some benefit. So there are, you know, many factors that are in themselves different across those various areas that, if you accumulate them all up, create absolutely unique and unmappable arrangements when comparing UEC system to UEC system. So that fundamentally is what I would add and say. You can't compare one with the other in reality. But of course, the UHNM position is challenged. The numbers aren't good. And I suppose I'd refer back to the conversation we had a moment ago around system pressures in terms of all the things that we're doing to try and address those specific challenges in Stoke specifically.
Janice.
Thank you, because my next question was going to be, well, which one out of the myriad of factors could be the ones that are most likely to be contributing as to why in June 22 one's 555 and another one is 30. So looking at the trolley breaches, that is, so there's some significant variances between those, and I'm sure that those system pressures, you know, would be the one that is highlighted as most attributable for it. But I think the more that I like data, so when you start going behind the data, then you start to get to the nub of what the problem is. So thank you for that.
Thank you. Does anyone else have any questions on the last two pages, 43 and 44? I'm not getting any indications. So, long couple of hours session, so appreciate that, Peter and colleagues. We're asked to note the report, and we duly do. I should probably just say two things, though. Actually, I think what this allows us to do is to drill down into more detail and have better understanding. So we ask better questions, and we're able to understand more about what the impact of the pressures are. Second of all, it's nice to see some data, because we don't always see data, so that's really useful. And it's nice to understand in more detail for those areas the action plans that sit behind the data. And I'm sure whilst none of it is particularly good reading, particularly with a level of red, I think it is a useful report, and I welcome those people who have not only created the report but also actually done the work to reduce some of those backlogs and issues. At that point, I'm going to move on to the next agenda item, so you're welcome to stay. We're going to move on to social care, you'll be pleased to know. And we have Dr. Richard Harling with us. We need to move to the so, Richard, agenda item 6, we're now with you. Gentlemen, ladies, you're welcome to stay or go, as the case may be. Thanks for your input. Richard, for reference, we're obviously running tight on time this morning. We've asked presenters to stick towards 5 minutes. So if you want to introduce your report and then we will move into questions, you should assume that we have read the report and digested its contents.
Thank you, Chair. So for brevity, very happy to take the report as written and perhaps move through it and take questions. Thank you.
So I've got Jill, who I've seen first.
Thank you, Chairman. Forgive me for not being able to, off the top of my head, call the date that this was actually written. But I'm just looking at 1C, which is maintain a market for care and support that offers services at an affordable price. In view of the colossal energy prices, is that something that might be revisited? Because I'm mindful of the cost of heating homes, etc.
Thank you. So I think the objective stands, that is one thing the Council wishes to see. I think you're quite right that the current cost of living issues, including the cost of energy, are putting pressure on care providers, as they are on all of us. And it is possible that those cost pressures feed through into price increases for local authorities. It is something we are monitoring very carefully at the moment, and we'll address it should we need to do so.
So, thank you, Richard. Can I just ask a question in terms of, under page 54, affordable and sustainable care? Obviously, one of the issues that is underlying within care is the rates of pay to actually not the agencies, but the workers themselves. Previously, I seem to recollect you talking about we were paying agencies £17 an hour, and the workers actually received 13. Can you assure us that that any increases that have gone towards frameworks and costs have actually ended up where we wanted them in terms of money to the people who are actually doing the job?
Yes, so when we offer fee uplifts to care providers, we do so with a clear expectation that that feeds through to pay increases for staff. We do not have the legal power to enforce that. However, there is a market dynamic that does tend to mean that that's what happens. Of course, those providers who pay staff more, on the whole, find it easier to recruit and retain, including attracting staff from other providers. So you do tend to get a levelling up approach. We do also monitor what care staff are paid, and we do tend to see that their rates increase as our rates get paid. It is not necessarily perfectly uniform across all providers, but it is a clear trend.
Thank you for that, Richard. And are there any other models in terms of that other counties have adopted in terms of dealing direct, for example, with employees? Because at least it ensures that money goes directly to where we want it to be.
On the whole, over the last few decades, the direction of travel across most local authorities has been for a greater outsourcing of care services, including home care and care homes. There are some local authorities that still have relatively higher proportions in-house than Staffordshire does. We are looking at the moment at establishing an enhanced home care service to provide additional capacity in the market, specifically to deal with some tricky issues around demand in some parts of the county where a shortage of capacity affects hospital discharges and affects people's choice. I think it is unlikely that the council would move to very large-scale in-house provision in the foreseeable future. I think it would be more a question of dealing with gaps in the market as they arise.
Thanks, Richard. Can I bring in Mike Whitcox, please?
Thank you, Chairman. On page 47, financial assessments, you state that you receive around 500 referrals for financial assessments each month, and yet we have 916 people still waiting longer than 28 days for their financial assessment to be completed. Do we know that the reason behind that? Is it down to capacity and staffing, or are there other concerns? And following on from that, it says that some people who are already in receipt of care have yet to be charged. Is there likely to be a burden placed upon those when they are assessed and you get round to it, that they will have a massive bill that they need to pay to move, to get themselves ahead of the game in relation to the services they receive in care? Thank you, Chairman.
Thank you. So financial assessments are a concern. I think there are two issues. One is an excess of demand over supply, and the other one is that the processes are not all that we would want them to be and do require some fairly significant review and redesign. Because there are delays in financial assessments, it has two implications. One is it results in quite a lot of complaints from people who are unhappy, and that's for exactly the reason you outlined, that they don't know what they're going to be charged, and then they do get a retrospective bill, and sometimes they challenge that. The other issue is it leaves the council open to financial risk, because if we don't tell people what they are supposed to contribute, they can't pay us, and then they accrue debt. So that is one of the priorities for the tail end of this year, is getting those processes fixed and getting this backlog down.
Mike, anything else? Okay, thank you. I did see Keith first this time, Janice, like I did last time. So I'm gonna come to Keith first because I saw him first, then you.
Janice was a follow-up, but never mind. No, just in terms of the difference in ratings between nursing care homes and rated residential care homes, say work needs to be done in trying to improve that situation. Is there any reason why that is at the moment? Is it just down to cost or anything like that? Or is there some programme to try and improve on that? And the same with the ratings in terms of our services overall. They're not as up to the level, shall we say, of the West Midlands services in terms of being good and outstanding. They're a bit lower. I mean, is that just a general overview for what we're providing at the moment, or is that something that's slowly improving? Because I can't see previous figures. That was all. Thank you.
Might invite Andrew Jeps to comment on this one.
So particularly in relation to nursing care, no, we don't believe that it's linked to funding, because we use a DPS system, so homes are able to bid, and they obviously do that based on what they believe is economically acceptable for them to be able to run a business. There are a lot of support we put into that sector, including jointly with the NHS. We have a quality assurance team, provider improvement response team, which includes nurses as a seconded to us from the NHS, and support from MPFT, a team called the Care Home Intensive Support Team that can provide sometimes hands-on clinical support and access to a wide range of clinical specialisms. There are some common themes, I think, particularly around clinical leadership, so the number and the capabilities and skills of nurses within those homes. So quite a strong focus on trying to improve access to training as well as that clinical support. So we have a wide range of approaches, but nonetheless, despite that advice and support, there do remain those quality issues as identified. One of the other things to be aware of is that during COVID, there was a change in the way that CQC carried out and prioritised their inspection regime. They are now carrying out a more normal approach to inspections, and that includes re-inspecting or further inspections for homes that have been requires improvement for some time. So you may well see a change, not just in Staffordshire, but across the country as that takes place over the coming months.
Okay, quick follow-up. I just wondered if integration into the community could be something, again, that you might be able to work with to try and improve those figures. I don't know whether that would help at all. I know that nursing homes probably won't do, but is that another reason why the residential care homes probably are better if they are integrated into the community?
It's probably one of the reasons, to be fair, and also because those people who are in nursing homes tend to have the highest level of risk and needs, and so just inherently there are more challenges perhaps need to be overcome. In relation to support in the community, again, we work very closely with our NHS and other partners, including with CQC regulators, to identify those services that need to be improved, and again, a very targeted and very precisely planned way of helping those services create their action plans for improvement.
Just a quick request, could we have those figures over the times on the future reports where we don't just have a comparison to what's been before, if you see what I mean, so that we can then see which direction that we're going in some of these areas? Would that be helpful? Yeah.
Just can I follow up Keith's line of questioning, because it did concern me. When we include in our figures care homes that have no rating, whilst it might be statistically correct, the reality is that I think we are misleading, or maybe I've got a different cultural touchstone there. Because actually the reality is, when you look at CQC ratings for community services, only 52% are good or outstanding. And there is a massive way forward to improve those services for our residents, in my view. So I was somewhat surprised with the report where I read it and thought, oh, that feels nice and warm and cuddly and glowing. And the reality, in my view, is not quite as it's identified. And the point I'm making really is, if you start with the report's position, you don't necessarily actively work with providers to improve the quality and to move them from inadequate and requires improvement to being good. And you don't also make some of those good go on the journey to outstanding.
Thanks, Chair. So we can't control the rate at which the CQC assesses care providers, and their rate of inspection is down compared to what it was pre-COVID. So there is this bulk that are unrated, you're quite right. In addition to the official CQC ratings, we do have quite a lot of local intelligence because, as Andrew said, we use our own teams to support providers. If you apply our local intelligence to the unrated, the majority of them we expect, if the CQC were to come and rate them, would be good. A few would be requires improvement. And if you overlay the local intelligence with the CQC figures, you get to an overall headline figure of round about 80% of all providers would be outstanding or good, which is pretty favourable compared to the England average.
Thank you, Richard and Andrew. That is a really useful response to that question. Janice, can I bring you in, please?
Yeah, Chair, I think that information in particular is really useful for that. My original question was following up on what Councillor Mike Wilcox had mentioned, and it was just to get a little bit of clarity on those points between 8, 9 and 10. So is the time frame to, I think it was to use additional capacity, exploring additional capacity, is that the time commitment to try and recover and catch up on those outstanding assessments that need to be done as well? So it's looking at the time frame and how it's going to be done.
So is that in relation to financial assessments or the Care Act assessments?
Yeah, so it was the financial assessments.
So I think we are looking at the moment at A, trying to increase the capacity in the financial assessment team, and B, to try and streamline those processes. We have recently decided that we will use a more limited range of information on which to base the assessment. It doesn't really affect accuracy very much, and it should hopefully speed them up. And we will be monitoring this very closely indeed. And if there are other process issues that need to be refined in order to allow those to go through more quickly, then we'll consider those as well.
Janice, anything else?
Thank you, Chair. The number of individuals who require assistance, appointeeship arrangements is very concerning here. And it must be the outstanding costs which will be incurred by this. The answer, as you say, is for them to have lasting powers of attorney. Problem there is people who don't have anybody that a lasting power of attorney could apply to because they have no family. However, it is important that awareness is increased, despite the fact that the Court of Protection is struggling under the number of applications at the moment. I just wondered what steps you're actually taking to increase this awareness amongst the public.
Thanks, Chair. So, with the adult social care reforms expected next year, one of the things we want to do is review and strengthen our information, advice and guidance for the public, both in terms of the content of the website, but also the presentation, to make sure things are as easy to find as possible. And we do want to include a section on something like preparing for old age, which would include advice about power of attorney, preparing your will, all of those sorts of things, just to help the public think about the sort of issues that will face them in later life, and ideally plan for those while they're still able to do so.
Thank you, that's fine.
So just looking around the room, Charlotte.
Yes, I want to focus on home care. You say in paragraph 41 that 89% of our home care is procured via a contracted home care provider. Does that mean that you have sufficient home care available? Because obviously I referred a case to you fairly recently where someone was left without care because she was unable to find a provider that met the pay threshold set by the county council, and therefore it required intervention to use a provider that was paying more. So do we have different demands within the county? Are certain areas particularly difficult for provision of home care? Because I think we all agree that if we can increase home care, we'll hopefully keep people out of residential or nursing care longer than perhaps we would otherwise.
Richard, before you answer, can you keep out of the specifics of the specific case mentioned, but obviously talk about the general point that Charlotte's made, please?
I think Richard's nodding to me. So we try to get a balance here between a consistent rate, because that establishes a reasonable, fair, level playing field to allow providers to run their businesses, and recognising that there's always some areas that are more challenging. One of the ways we deal with that is that there is an enhancement for the more rural areas that's on our framework. The areas where we use providers that are off contract just vary all the time, so there's no one particular place. It can be driven by short-term gaps. For example, if there's a provider who's had challenges around quality, maybe there are new providers who are coming in, but we don't want to overuse them. Sometimes it's to do with a change in the local economy, so there might be a new part of the economy opening up that's starting to create competition. So there's no one particular theme. That can occasionally happen, but also it can also be that there are other roles within health and care, so other services that can also be attractive. So the balance between aiming for a target of around 90% on our framework, but allowing that ability to flex, seems to be a reasonable balance between affordability and being able to maintain supply. But it's like painting the fourth bridge. We're at it all the time in terms of where we have that 10% or so.
So in general, there's not a shortage in terms of care individuals providing a service to people at home. I mean, because certainly in many authorities, there is a significant shortage of carers available to mop up the needs of the population.
There certainly is a real challenge around both recruitment and retention and a vacancy rate which was around about 6% a couple of years ago, and we estimate will have increased as the economy opened last year. That is filled by a combination of agency workers and by staff being asked to do more hours. We've put a lot of support into that sector, both through our care market development team, which provides access and encouragement to learning and development, and by an increase in the rate that we pay for home care last year. But it does remain a very challenged area, and one of the reasons why we work with colleagues to develop a wider systemic approach to supporting the workforce.
Okay, thank you.
Brilliant. Thank you, Richard and colleagues. I'm not seeing any further indications. I note we've been asked to note the performance of adult social care. I think Andrew's last comment was it's a very challenging environment, and if we thought that the NHS was, we should not ignore the impact on social care. So thank you for this report. Clearly, it's an ongoing discussion in terms of quality and availability. I also note that we've got the Care Act that we need to upskill ourselves and review to understand the impacts of, and then have a discussion around the impacts on Staffordshire locally, which is something which we will need to diarise going forwards, just to make everyone's day. But otherwise, thank you for the report, Richard, and I think it's a useful summary of the direction of travel and what's happening in the detail. So let me move on to the next agenda item, which I think is the future of supported living services in Staffordshire, item number 7. Colleagues are welcome to come or go. Richard, do you want to say a few words, or how would you like to handle this?
Thank you, Chair. So if I perhaps just give a quick introduction, and again, if we take the paper largely as read and go to questions. Supported living schemes typically offer accommodation for people with a range of disabilities. There is usually a specialist housing provider alongside a care provider. We currently have about 500 people in supported living placements at a gross cost of just under 30 million per annum. At the moment, the way the system works is that we buy placements for people one at a time as they need them. There are a range of issues with that which were highlighted in a previous Cabinet report. So that Cabinet report included some draft recommendations and then a request that we go and talk to people about those recommendations and get their views. It is now going back to the October Cabinet with a summary of people's feedback and a final set of recommendations which are set out in paragraphs, I believe it is 9, sorry, just looking at the thing, so paragraphs 3 to 7 in the report. So this basically sets out how we think that we will be commissioning supported living in the future through a series of block contracts and all of the other things set out in the body of the report. Thank you.
Thank you, Richard. I'm looking around the room, so that gives me an opportunity, given no one's indicated, for me to start then. This time I will. Come on then, Janice.
I was just curious. In the Appendix 1, feedback from stakeholders, there's a line that mentions about that all 8 either district and borough councils were invited to a Teams meeting. Did all of them attend?
Might have to defer to Kate if she's on the line on that point. Oh, sorry.
Hi. We invited all of them. They all the district and boroughs had a representative at their everybody we invited didn't attend. I could get the full figures for you, but we did have a representative from each of the district and borough councils.
Thank you. I thought it was a lovely hologram, Kate, and it's nice to see you. I do have a question I just wanted to ask. I'm aware that North Staffs Combined has been looking at supported accommodation. I'm pretty sure that MPFT has also been looking at supported accommodation, and now the County Council is looking at supported accommodation. So it does surprise me somewhat that we haven't looked at joint commissioning. I note there is a line in the report which talks about, well, everyone else can buy off ours, but if everyone else takes the same approach, then we all carry on in our individual corners. And I haven't understood fundamentally why we haven't looked at joining forces, not to reduce the cost, but maybe to see if there are other models out there.
Yeah, it's a very fair point, Chair, and I think doing things more jointly with the NHS is something we would want to pursue. In terms of the timescale required for this specific piece of recommissioning, we have until September next year, so there is a reasonable imperative of time. I just think in terms of integration with the NHS, we're not yet at that level of maturity that would allow us to do it fully jointly, but we'll continue to work towards that over time.
Yeah, I hear that. I mean, albeit I do know that North Staffs Combined are probably 6 to 9 months ahead of you. So I wonder whether there would be some value in at least, you know, reaching out and seeing if there is some benefit. Otherwise, there'll be another 5 or 10 years that will go by where we can't take the benefit of integration.
If it's helpful as well, there's a particular cohort of people that North Staffs Combined do seek to meet their needs for, particularly those people who are coming from long-term hospital placements. We track those jointly. There's a Learning Disability and Autism board, which I co-chair alongside those colleagues. We track those, both the market challenges, but all the complicated issues that sit within the hospitals as well. And there's a particular level of expertise that is required, and skill and capability, which is why North Staffs are appropriately in the lead there, but we share our market intelligence. We're also sharing this kind of information that you can see here and our wider strategic analysis with partners across the whole of our markets to identify those possible ways forward as well. But I think the cohorts you refer to have an additional set of particular complex needs and risks that are best managed in that way, but we are entirely aware of the plans and the work that is done by Combined around that particular cohort.
Thank you, Andrew and Richard. Understood the answer there. Keith.
Just following up on that, we're talking about Staffordshire Borders. We had service delivery last week where we had to consider what we're going to do with our own services to put people into, you know, look after them while they're in their own homes, as it were. So is that part of this whole process, or is it just something that is monitored by yourselves, or does that not come into the actual this element of it, which is the commissioning of supported living services, or is it both specialised homes and or taking people's homes and specialising their homes? Because we were vastly underspent, I think, and we were providing better services. And it did seem to me that when we did work together, which is what Jeremy did turn up, it didn't quite work quite as well as we expected. So we've had to now look at other people to provide that service.
I think that might be something slightly different. I think that sounds like Disabled Facilities Grant, which is the district and borough responsibility. No, that's out with of these, yeah.
Okay, I'm not seeing any further indications, so let me carry on then. Question I've got relates to the length of time of contracts. I know you say minimum of 5 years and maximum of 10. If I look at some of the people that you're likely to be talking to in terms of registered providers, they want some financial surety because they're investing, and at the end of the contract they need to make sure that they've been able to recover whatever they've invested into that, which I think is only fair and right. And so are we convinced that you know, a 5-year contract gives them enough time to be able to recover that, first of all? And second of all, from a resident point of view, from a I don't want to call them patients because they're not patients, but from a resident point of view, we would presumably not want to be moving people on a regular basis every 5 years. So actually, is there an opportunity to be a bit bolder here and say, it should be a longer contract than you're indicating and inferring here?
I'll just come to Kate in a moment about the contract. Just to be clear that with supported living, in the vast majority of cases, people's housing arrangements and care arrangements are separate. So they have a right of tenancy, irrespective of whether the care provider changes. So at the end of a care provider contract, they don't have to move out. They simply get another care provider come in. It's a bit like if you had home care in your own home. It's the care provider coming in. Kate, do you just want to comment on the length of contract?
Yeah, so at the moment, for the block contracts, we're looking at between 5 and 10 years. So that's 5 plus 5. We need to put a break clause into the contracts to allow the providers to look at the current environment and allow them to come out of the contract if they need to. But at the moment, we're looking at a 5 plus 5. And we are setting up provider forums, and we will be working with them to inform what the spec looks like.
Thank you both. I think that you've asked us to consider the feedback and to give you our input. I think you've had our esteemed input. Is that clear enough for you to be able to take back to Cabinet when you come to make those decisions, Richard?
Yes, I think it is, Chair, and thank you very much for the feedback. If it's okay with you, what I'll do is to quickly précis the comments from the committee under paragraph 7, send that back to you for approval, and then that will appear in the final edition of the Cabinet paper.
That would be perfectly fine with that. Thank you, Richard. Okay, swiftly we move that now on to clinical policy alignment, I think. We're back with Tracy. It's the musical chair show.
We also have people online.
And I should not forget the people that are working with Tracy online. So welcome some new faces. That sounds like a pop group. But welcome and apologies for the time. We're running relatively tight to time. So can I suggest maybe 5 minutes introduction and then throw the floor open to input. Tracy, are you leading us?
Yeah, I'm going to hand over to Gina Gill, who's going to give the 5-minute introduction, and we're aware of the time pressures. Thank you.
Thank you, Tracy. And just to note, apologies from Paul Edmondson-Jones. He had planned on attending today, but is not able to. So in terms of a quick 5-minute introduction, this work looks at the alignment of 5 key areas and the alignment of those clinical policies. This work started back in 2018, where we reviewed eligibility criteria across Staffordshire and Stoke. A number of these areas were aligned already. We were able to alignment as we recognised there wasn't necessarily any material change for those. Oh, sorry. These did not necessarily change patient pathways, so these were aligned. However, for these 5 areas, these have been through our prioritisation process where they fall below the threshold for commissioning, or they require eligibility criteria. So recognising that this would be quite a change to current process, it was agreed that we would go through an involvement process and an options appraisal process to understand the impact of those before recommending any changes. This involvement phase started in January 2022, where we had some surveys and patient events. Sorry, I need to stop looking at the screen, seeing the slides flicking through. Some patient events. We, of course, had to pause because of COVID. And while the resource, clinical resource was focused on managing the pandemic. We restarted this again later on in 2021 to understand if there was anything different as a result of COVID from what people told us back in 2020. Going into 2022 then, we did some further involvement with the public. We ran some technical events to start developing the proposals for these 5 key areas and refining those proposals through that process. We had a range of clinicians involved supporting that, as well as our quality leads. These then, through that process, we ended up with one proposal per clinical area, and these are detailed in your paper. Following those, we've undertaken quality and equality impact assessments on each of the individual proposals, and these have been taken through our internal governance process. So they've been to our Finance and Performance and Committee and our Quality and Safety Committee, where they approved the recommendations within the paper. They also recently went to the ICB board meeting, where again the proposals were approved. So then in terms of our next steps, we are here with the committee to ask for your support in the implementation. Now it will be slightly different. So for 4 of the areas, that is male and female sterilisation, breast reconstruction and augmentation, hearing loss, and what was the final one? Body removal of excess skin following significant weight loss. We would look to issue a 1-month notice to providers once we've presented it, both this committee and the Stoke Overviewing Committee. It would be with a 1-month implementation, and then we would change local policies. From that implementation, what we would do is we would honour anybody who's currently on a waiting list who was approved for treatment under those current policies. We've got a strong comms plan to ensure that we are communicating out what those changes are, and support for patients is available through our patient advice and liaison service. For assisted conception, this is slightly different. So we've recently had the publication of the Women's Health Strategy, which has indicated that there will be a national review of provision for assisted conception services. We're not clear on timelines, but we are aware that the NICE guidance will be reviewed with an estimated publication date of 2014. So what the board's agreed in the interim is that we develop an interim aligned policy, as we currently do have 3 different policies across Staffordshire and Stoke-on-Trent. And then once these policies have been reviewed and developed, they would go back through the governance process for approval. And you'd be looking at around May next year for potential implementation of those. So I'll just hand over Helen and Steve. Was there anything else you'd wish to add there?
So just to confirm, 2024, not 2014. I think it was a.
Oh, sorry.
for the guidance, national guidance.
Thank you.
And the only bit sorry, Chair, the only bit I'd want to add is that the review's been driven by the evidence. This is very much a clinically driven and evidence-based approach that we've taken. And I think it's important just to bear that in mind.
Thank you, that's useful. So I think just if I can preface the questioning, today is the 6th time that this element has come in front of us. And so none of this will be new. Our role today is not to reinvent the clinical review process, but to look at the proposals as they stand in front of this committee. And I should just pay I should just pay tribute to the previous chair, County Councillor Dr. Johnny McMahon, for the work that he did in making sure that this was an issue that the committee regularly kept on its radar and agenda. So, thank you. Charlotte Atkins.
I'm sure, as Johnny McMahon would agree, this particular report encompasses an absolutely disgraceful commissioning episode. Back in 2015, North Staffordshire CCG decided to take away free NHS hearing aids from people.
Charlotte, I think we've probably already, the 6 committees previously, already been through this.
But
can we comment on the forward proposals, please?
We just heard that this is the clinical evidence. Well, back in 2015, that same clinical evidence was available to North Staffordshire CCG. And for 7 years, for 7 miserable years, people have been denied free NHS hearing aids in the north of the county. Now, the point is that, okay, this is now they've now decided that not just those people with moderate hearing loss, but those people with low hearing loss should also now get NHS hearing aids. And I dispute the fact that this was based on clinical evidence, because this committee had a workshop on that day, and the various other CCGs, in line with the rest of the CCGs in the whole country, would not embrace the idea of taking away free NHS
Charlotte,
hearing
I think
aids
we've
from
probably
local
been
people.
through this a couple of times already.
I'm
happy to ask our guests to answer the question in terms of the clinical evidence, but effectively we're looking backwards, and I'm trying to look forwards on this one. Can you just conclude with what you were going to say?
Well, yes, I mean, the question I want to ask is, how can we have confidence that these decisions are based actually on clinical evidence when you can have such a huge outflier in terms of one CCG making a different decision from the rest of the country? So that's what worries me. You know, we went through the workshop of the various systems used, but these are the same systems which are being used now. So how can we be sure that future decisions are made on real clinical evidence, and not that we shouldn't take a different view from the rest of the country? I think it's a very important issue, because these decisions are being made all the time, whether it be on assisted conception, whether it be on obesity surgery and so on. It is an issue which there should be some consistency. We're always talking about, you know, a lottery in terms of healthcare, and I think it's really vital that this committee ensures that we're not part of a lottery, that we are part of a clinical process.
So I think there are two questions in my mind. One is the one that Charlotte's just framed at the end, which is about, you know, can we be assured or reassured that this is based on clinical evidence? But can you also just give us those key milestones in terms of the original decision on commissioning intentions in terms of mild and moderate hearing loss, please?
I'll probably start off. I probably would want to be, as you were, Chair, wanting to look forward, not wishing to negate Councillor Atkinson's report comments. I think that the key bit is that the evidence has changed since the original decision was taken in 2015. As Charlotte will be aware, there was a substantial NICE guidance report, National Clinical Guidance, published in 2018, which actually did change the assessment and the use of hearing aids for mild to moderate hearing loss. So I think this process represents the fact we have reviewed the evidence, we have reviewed decision-making process, and we have, if you like, we're revising the guidance. That shows we're capable of change based on changing circumstance. In terms of process, the process for assessing for clinical evidence is really fairly detailed and fairly exact. We do a very large evidence review, and it takes a fair amount of time to do that, because we have to collect all the relevant literature from research and from other review places, and then we have to sit there and try and go through it line by line and look at it analytically, rather than trying to second guess people's impressions or feelings about interventions. We also then have to take into account a whole series of different factors in terms of cost effectiveness, whether it meets national guidance, whether it helps reduce inequality. That it is a non-trivial task. But what I would say is that all the time we are looking at new evidence comes through and trying to make sure that we plumb that into our decision making. Because we absolutely want to do the right thing by our patients, but we also want to do the right thing by our overall healthcare system.
It seems a very long process for each CCG or each integrated care board to go through this evidence, and it's happening all around the country. I mean, why do we have NICE and other evidence producing bodies if every single health organisation has to go through this long, convoluted process? It seems to me, I appreciate that we are providing for our own local patients, but, you know, the difference between what happens in Manchester and what happens in Staffordshire is not great. And it just seems to me that, given the crisis we're in the NHS, that we're putting a lot of resources into recreating the wheel.
I mean, I do really want to focus in on, sorry, Steve, I do really want to focus in on the report in front of us rather than national policy. But Steve, I'll let you make a couple of comments. And obviously, there is a role for the clinical synod here, or Senate here, and making sure that those guidelines actually come into local practice, isn't there?
There is, Chair, and the clinical senate will be very important going forward in terms of making sure that the clinicians from every aspect of our system and every discipline has got the ability to influence and support our prioritisation efforts. I take Councillor Atkins' point again about having local versus national decision making, but much of it will come down to what in terms of our local needs, our local priorities, and you know the policy is that localities and ICBs will have control of their own commissioning decisions. But one thing I would say is that actually moving from 6 CCGs to 1 ICB in Staffordshire is incredibly helpful, because it means that we will remove the level of, if you like, almost postcode type effects that we have had within the system. So this is very much progress going forward. We are looking to do this on the whole system footprint, which I think from system partners' point of view is much preferable to the work we've had to do in smaller system arrangements that we've had to do up to date.
Well, I don't really want to give you another opportunity to come back, but do you want to? No, that's okay, thank you. But I think you make some really good points in terms of, you know, is this based on clinical evidence? And I think that was where you started. Anne Edgeler.
Thank you very much, Chairman. And just picking up on Councillor Atkins' comments there. I mean, I sat on this committee now right from the beginning, as Charlotte has, regarding the hearing aids in North Staffs. But it's like everything, moving forward, we have to learn, and let's hope the Commissioner have learned from their mistakes. And it's up to us now as a committee to make sure that these people do their job correctly and make sure in the future that this doesn't happen again. And let's remember, it's the good work of this committee that we kept hounding about this. So I pay compliments to this committee for the work that was done on that, and let's move forward. Thank you.
Steve, do you just want to make any comment in terms of what Anne's just talked about, particularly in relation to the ICB intent, or the ICS intent, because you know that's clearly part of that, isn't it?
Yeah, I'm not sure I'd characterise the process today as correcting mistakes. What we're doing is we're trying to we re-evaluated evidence, and we're revising our approach on the basis of that, not because and colleagues may have a different view, but we're generally trying to do this because the situation has changed from the time we made the original decision. I mean, it's taken a long time to get here for all sorts of different reasons, but not least of which because of COVID and other events a little bit beyond our control. But I do recognise the fact that it has taken a long time to get here. Sorry, Chair, what was the other part you wanted me to touch on?
Yeah, just, I mean, some of this goes back to the intentions of the ICS to ensure that the decisions are based on clinical need.
Yeah, so we to be fair to the CCGs that were the predecessors, they've always done it on the basis of need, effectiveness, and overall and resource. I don't think that paradigm has changed between being a CCG and an ICB. I think what has changed is that we've now got a mandate to do it across the piece and do it once for all. So I think our underlying mechanisms and approach are the same, but I think the way that we're organising it is now, as I say, there's not an economy of scale, but it's done, as I say, we do it once for everybody rather than doing it in necessarily a slightly siloed way that we might have done it before. Is that what you were trying to push at, Chair, or have I missed the point?
No, absolutely. And is there anything else you want to come back on? Okay, thank you. I've got no more chair questions from the floor here. I think the report's, as I said before, we've been through this a number of times. I think the report is comprehensive. I personally, and I'm going to see if we get some nods from around the table, I personally welcome the pragmatic approach that is being taken, particularly in relation to interweaving this decision with the Women's Health Strategy, because there's no point in setting out on a direction of travel that it goes in the opposite direction to that strategy. So I personally welcome that pragmatic approach. I wish we could be more pragmatic on other things. Secondly, obviously this is principally a benefit in terms of those residents in North Staffordshire, as Charlotte has been talking about, that have been not able to access mild hearing loss support. So are we as a committee in favour of the proposals in front of us? There you go. Nearly unanimous. Maybe it was unanimous. Who knows? Please, can you feed our comments back into the Integrated Care Board? And thank you for moving this on to a conclusion. And hopefully, other strands of activity won't take quite as long. Albeit, I think I understand exactly why it has. So that takes us on to our penultimate element for this afternoon's meeting. You're welcome to stay or go as the case may be, ladies and gentlemen. Thank you for your input. Not councillors, sorry. I think we're on to a district and borough update. So I think we can take this as read. Can I just make two comments? First of all, we will provide you, because of time, with a written update for Stafford Borough, because I think we've managed to duplicate paragraphs for those observant amongst us. And second of all, some of the updates, stray out of health matters. Given this committee is interested in health and well-being and, sort of all those sorts of things, I'm not convinced we should be reporting on police matters or on recycling services, as beneficial as they are to our residents. So has anyone around the table got any updates with meetings that they've recently had that they want to update committee on? We will bring it to the 17th of October meeting, so given I'm not getting anyone vehemently putting their hands up, that brings us on to the final item for this afternoon's meeting. And thank you everyone for your indulgence right the way through. It's been a long meeting, but hopefully we'll have caught back up some of the stuff we didn't get to a couple of weeks ago. I think we agreed, in addition to what's in front of you on pages 128 and 129, and even 130, to diarise something in terms of the mental health strategy. With your permission, I would like just to look at the 28th of November. Instead of just looking for a primary care update, I think we should also be asking about what the model for future provision is. I think we're aware that the ICS, previously the CCG, talked about looking at having a better standardised patient-resident pathway. I think it's about a year since we talked about that, so I'd be very interested to see that. And Tracy?
Just a suggestion, Chair. Following the fuller report, you may want to see how we're taking those issues forward, and as part of that, so I'll ensure that's done.
I always value your input. Thank you, Tracy. Very helpful, as always. And just in terms of other things, in terms of schedule, we've obviously had to move stuff around. So apologies to Councillor Edgula that we've had to move the Healthy Communities workshop. It doesn't reflect the importance of that work. I think we all buy into that. Unfortunately, we've had to move agendas around when we lost the meeting, and that's now scheduled and diarised for the 28th of November. And at the last meeting, we did agree to diarise something for dentistry, and that we've scheduled that for the 20th of March. Is anyone indicating? My goodness me, we're 5 minutes early. I didn't think we'd ever be that. Okay, I will close the meeting at that stage. Thank you everyone for your input and engagement, and have a good rest of the day.